Good morning, everyone. Welcome to the second day of spaceflight for everybody. Dr. Siegel, did you have a few comments that you wanted to make?
Just that we are so pleased to see so many people that joined us yesterday, and it was a day full of incredible amount of information, and I look forward to hearing today's speakers as well. And so I'll turn it back to my co-host, Dr. John Allen.
So again, good morning. I'm John Allen. For those who weren't here yesterday, I'm a program executive for Crew Health and Safety and for the Human Research Program in the Space Operations Mission Directorate at NASA headquarters. I've got the privilege of being co-host with Dr. Siegel, but we have a person sort of lingering in the background who hasn't gotten any attention during this, except for the fact that he's been the master of managing all the questions, and that's Dr. Victor Schneider. Dr. Schneider, also a program executive in Space Operations Mission Directorate, but works between SOMD, Space Operations, and the Office of the Chief Health and Medical Officer, and has been incredibly helpful during this preparation of the symposium. And he will be the one that will be managing questions in the background. With respect to those questions, there's a Q&A box or tab on your computer. And if you have questions, feel free at any time to go ahead and enter those in there. We will get to as many of those questions as possible. That possible comment is really the critical point. We will certainly not be able to get to all of them. But if after the symposium, if at all possible, again, we will try to get back to you and to address the question that you may have for any of the speakers. Other housekeeping issues here. Besides that, we also are, you'll probably notice that we're recording this, the entire symposium. The recording will be available on the NASA YouTube channel. We don't know exactly when that will be. We are checking with our tech folks to try to find out. And if at all possible, we will let you know before the end of the symposium when that will be and give you the link to that. We believe that will probably be on the webpage where you registered. So if that's not the case, it will be on one of the NASA YouTube channels, and you should be able to find that and search for that pretty easily. In addition to the recording portion, we will be having sign language interpreters through the session. One of the reasons for the somewhat modified view that you see here, we do this so we have very good visibility of our interpreters. If you need to expand the screen, Ricky may have gone over this with you earlier. If you need to expand the screen so that you can see the slides more easily, so where you see space flight for everybody now, just grab the side of that screen and drag it to your right, and it'll make that a little bit bigger. But if you need to see the interpreters better, you can do just the opposite. For those who are presenting, I would ask you to remember to mute your mics and your cameras when you are not presenting. But if you're on a panel session, when it comes to that panel, if you would go ahead and each of you open your cameras so that we can see all of you, because the questions will likely be directed to all of you at some point in time. I have back to the note with my comments with respect to our interpreters. Our speakers did an amazing job yesterday of not speaking too fast. We from NASA are used to having interpretation, not necessarily sign language, but interpretation of our comments. So try not to blaze through your slides. I realize timing is an issue, but see what you can do with that so that our interpreters can keep tabs and keep up with us. Just one little announcement. We got an announcement late last night. You may have seen already that our SpaceX Crew 2 astronauts, Shane Kimbrough, Megan MacArthur, Aki Hashide, and Thomas Pesquet, have all returned safely and have been recovered from their spacecraft and are probably undergoing all sorts of biomedical testing at the present time. So it was really great to hear that happening. Yesterday's discussions really set the stage for today by giving us an understanding of the plans for moving beyond low Earth orbit and the International Space Station. We learned of the risks and hazard of spaceflight, the management of health of those who are in the astronaut corps, and the research that's conducted to help mitigate the identified risks. Today, we move on to learn more about what it's like to live in the multinational environment of space, what it will take for humans to live in space and on other planetary surfaces, what it'll take to build systems and habitats that integrate the human, and to understand in greater detail the standard setting and management process that goes into protecting the astronauts. Well, throughout all of this, you're going to hear from an amazing group of speakers. And we are focused to a certain extent today is on some of those women leaders in positions that we have today that are contributing greatly. But it will be both men and women in presentation today that have been making those contributions. And one of those who's contributed significantly is our first speaker. So it's my privilege to introduce Dr. Serena, a non-chancellor. She was selected in 2009 by NASA into the astronaut corps. She's board certified in internal and aerospace medicine. She served as a flight engineer and a flight surgeon, but she served as a flight engineer on the International Space Station for expeditions 56 and 57. And during her time on orbit, the crews contributed to hundreds of experiments in biology, biotechnology, physical science, and earth science aboard the International Space Station. Investigations led to new cancer treatment methods and algae growth in space. The crew also installed a new life sciences glove box, a sealed work area for life science and technology investigations that can accommodate 2 astronauts. During Serena's first flight, she logged in 197 days in space. And by the way, during all this time, she's also been involved working in the commercial sector with Space Adventures, and not the least of her contributions over the last 2 years since the beginning of the pandemic has been caring for COVID patients. So like so many of our astronauts, so many of those that are involved in space exploration, so many of you, just an incredible person with incredible background and a friend of mine, which I'm glad to say. So let me introduce Dr. Serena, non-chancellor. Serena?
Thanks so much for that introduction, and good morning, everyone. Let me get my slides up. All right, and I believe you all can see the slides, is that right?
Yes.
All right, fantastic. Well, and good morning, everybody. I'm really happy to be able to speak with you today, and I want to thank all the folks who made this symposium possible. Dr. Allen, Dr. Seal, there was a huge team of people that came together a while ago to begin to symposium together, decide on topics to look at, what was important for us to sort of talk about, describe. And yesterday, as Dr. Allen mentioned, you heard a lot from the research community. They really did a fantastic job. In the NASA community, it's a family. So I consider all of these folks my friends, and it was just neat to hear from them. And, Dr. McPhee, Dr. Simonson, Dr. Shaw did a fantastic job. And it was nice because I felt like today I could roll into topics that were a little different. I will tell you what I'm going to talk to you about today are the practical aspects of living as a woman on board the ISS, and also some of those aspects of training. These are what I'm going to talk about are topics that I get asked frequently about during talks that I give really around the globe. So these are not new topics for me to talk about. Usually when I go talk at universities, both international and national, the audience usually focuses on some of these things. And so I think it's important to talk about not only as a woman, but also as a practicing physician, because the health of women are very important, especially the health of women in space. The health of everyone in space is important. But these are things that maybe you always wondered about and no one's ever said anything. So here we go. All right. So let's start with urine collection. So the actual act of urinating on orbit, what you can see on the slide there, what I call daily ops, really, it's very doable. So in this picture, you see me holding two basically urine hoses with funnels. I'm basically exchanging those out. And then you see some panels open behind me as well, because we were doing some internal work on our waste hygiene compartment, or what we call our WHC, our beloved toilet. Yeah, we really take very good care of this toilet on orbit. It is not fun when it breaks or when we need to perform maintenance. And so I had the job that day of switching out the urine hoses, and those are the funnels that we urinate in that you can see there. They're varying types. There's really not too much difference between the two that I'm holding in my hand. There's some slight shape changes. But, so this is something you have to learn when you get up on orbit, is urinating into that funnel. Obviously, on the ground, we all take for granted how much gravity assists you when using the restroom. And so up there, it's not that easy. And so but it's something that is a learned task. You learn it very quickly. Obviously, you have to. And I will say that as much, I didn't have too much anxiety about urinating in a funnel like this and aiming and everything before I got up there. I had a little bit though, but once you get up there, you realize it is very doable like any other task. It's something that you adapt to. Now, the collection of urine for science, which is critical, especially for those of us spending long periods of time on the International Space Station. I collected, we do something called a 24-hour urine collection, which is important for a variety of reasons. We do this in medicine all the time, so it's very common. But we had to do it for science on board ISS. That is a little more tricky because at that point you're using a urine collection device. And it's a smaller opening for which to urinate into. You're trying to go past a check valve into a bag. And so I really had to work at this to learn how to do it, because it's just a little bit more difficult for a woman than say it would be for a man. I will tell you, I actually called my good friend, Dr. Kate Rubens, when I got on orbit, because she had already flown, to learn tips and tricks and techniques. And I've talked about this in other presentations I've given around the globe. And eventually you do learn. So I will tell you that there is constant re-engineering of the urine collection device. They're always looking at ways to make sure this becomes easier and easier for our women astronauts, to be able to collect that urine for science. It's not easy for the men either. They have their own device. But I will tell you that it can be frustrating at times. It was frustrating for me at first. Then once I found a good technique, I was able to do it. So when it comes to urine collection, just use of the WHC, women are very used to doing number one and number two, what we call simultaneous urination and defecation at the same time. This is still possible up on orbit. It does require a little more finesse and technique. And so sometimes what you'll see is women will actually split those two operations out. I don't mean to be kind of sort of just very technical about it, but it is what it is. And so sometimes what women will do is urinate fully first into the funnel and empty their bladder, and then go ahead and defecate in the remaining portion of the WHC. And that is a technique I learned on orbit. It was not difficult, and I did it my entire 180 days, I'd like to say, without incident. Because the biggest thing we worry about, of course, is contamination of the cabin with any urine or feces. So we're always trying to avoid that. But this is something that it's not easy to engineer and to design. And so I think as we push further and further out back to the moon, on towards Mars, these are devices that we're constantly going to have to look at to say, how can we make this easier for crew members on orbit, both men and women? Certainly to keep the habitat safe, but then also collect what we need for science. Menstruation. So I get a lot of questions on menstruation. I think the first assumption a lot of folks make is that all women have to suppress their menstrual cycle on orbit, and that is not true. This is a personal decision. The agency does not tell you what to do one way or the other. It is your body. And so we have, varying percentage of women astronauts who choose to suppress their periods, and they can do that using certain types of oral contraceptives. We tend to avoid the injectable contraceptives because of that greater risk of bone loss, and bone loss is still an issue that both women and men face on orbit. And then we have women who choose to have their period even during an entire 6-month or a year-long mission. And so this is, again, a very personal choice. One thing you do think about, though, you look at the individual health of the woman astronaut. And with the new DVT risk that Dr. McPhee talked about yesterday, that you've probably seen in the scientific literature, this may come into play. Oral contraceptives are a known risk factor for DVT formation on orbit. I think, you know, for all you physicians out there and medical personnel, I think just being in space itself is a risk. You get this massive fluid shift towards the head and sort of more stagnant flow. And so it's one of these things where I think folks are already at risk for more stagnant flow and thrombus formation on orbit. And could oral contraceptives contribute to that? Of course, it's possible. So again, though, it's a choice. When we developed the space station toilet, we made sure that it could handle menstrual products. It can handle menstrual blood. The pictures I have on the left are what you see is what a filter. So if you are on your cycle on orbit, then you take that little filter, put that into the urine funnel, and that filters out any tissue. The one thing the toilet doesn't do well is filter out tissue products. Blood is fine, but just not tissue. And so there are plenty of these on orbit for women to use. I will tell you, it's, you know, if we have plenty of products available up on ISS during the time of the menstrual cycle, you're never in short supply. You can fly your own personal products if you want. And so the thing I like about this is, you know, the NASA engineering community, the entire community does not view the menstrual cycle as an inconvenience. It is a part of life. It is what women do. And so we view it as, hey, it's your choice. We will support you either way. You just let us know. So for me, you know, I think for a lot of women astronauts, that was very, very important. The cool thing, I will tell you, and I apologize, I didn't have a better picture of this article. This actually was just accepted a day or two ago as a publication. This is a new article coming out about, no kidding, menstrual management in the spaceflight environment. So I will say there's been a lot more focus on women's health issues, especially managing the menstrual cycle successfully and keeping the woman astronaut healthy. And you see a lot of these names on here. I will say that the bottom person, Dr. Richard Jennings, is well known in this area. He is an aerospace trained OBGYN physician, former chief of the NASA Flight Medicine Clinic, and he has done a lot of work from way early on looking at women's health in the spaceflight environment, women's health in the training environment, and you'll find even more articles written by him as well in the past. But this is a new one that should be coming out soon. And so I'm looking forward to sharing it with people because this is very, very important. And in this era of burgeoning commercial spaceflight, where we start to see longer and longer missions, these are the questions that are going to be asked by your women crew members. Pregnancy and fertility preservation. So when women come into the Corps, a lot of times they're in their upper 20s to kind of early 30s. Really, you know, that's kind of your prime age for childbearing. And so for active crew members, for active women astronauts, they may choose to delay that childbearing for one reason or another. It could be due to training. It could be due to spaceflight, which is coming up. It could be due to certain occupational exposures, which, you know, we are still investigating, of course. So I will say that NASA's Fertility Assistance Program, which has been around for some time, is one of the most forward-thinking programs I have ever seen. This agency has done a really nice job providing both, you know, its women and men astronauts with a program to help preserve that fertility, to allow them to be able to plan for families in whatever manner they choose. No one demands a time frame. They don't encourage, you know, pregnancy or childbearing at a certain point in your career. That is your choice, you and your family's choice. Now, if we do have a woman astronaut that becomes pregnant, they can still train. Now, obviously, training is multifaceted when you're training for a mission, or even prior to training for a mission. You have oodles of classroom training on space station systems, on launch vehicle systems, even on robotics training. Then you have your more high-risk training, sort of in altered environments, such as the T-38, or as you're training for spacewalk runs in the NBLs, the hyperbaric environment, maybe a mixed gas environment. We are very careful about putting any sort of pregnant crew member in the extreme environments to make sure that mother and baby are safe. And we have a really nice set of guidelines. that have come out to allow folks to plan their training, to sort of redirect and replan training schedules around pregnancy if we need to. So again, it's not easy. I won't pretend that it's easy to, be pregnant and train at the same time, obviously, because then there's the postpartum time period that you have to worry about, and being with your family, being with the new child. But we are as flexible as we can be with those schedules. And I think it's very, very important in the astronaut office, certainly, and across the agency to make sure that family is really emphasized. So the other thing that comes along with that is, remember, for federal civil servants, you get 12 weeks of paid parental leave, which I think is amazing. And we have private areas to pump to ensure that if mothers choose to breastfeed, they can do that. And so again, this is, I really believe NASA has been very forward thinking in all of these areas. And when I look around the country and the globe today, and I look at folks where that's not offered to their employees for one reason or another, I'm very thankful that these programs are in place. So topics we discuss around the dinner table, and when I mean around the dinner table, I mean floating around the dinner table on ISS. This picture on the left is myself and Colonel Ann Mclean, and she launched, of course, after we had the Soyuz abort in October of 2018, she launched very quickly afterwards with her crew. And I will tell you, it was really cool being the only American and a woman on orbit. And when we got time to hand over to the next crew, I was able to hand over to the next American, and that being a woman, Ann Mclean. So this was neat. What you see me holding is actually a small cartridge that actually goes into a centrifuge. We were looking at material science experiments at varying levels of G and how cement formation occurred. Very cool, but we'll go back to the topics. So these are the things, though, that when the crew's up there and we are floating around the dinner table at night, that we talk about. Radiation, space radiation. You heard Dr. Simonson give a fantastic talk on this yesterday. We know on board the ISS, we are very well protected. You've got tremendous shielding from the vehicle itself. You are protected by the Earth's magnetic field, still by the atmosphere. So we feel very protected on board ISS and low Earth orbit. We know that that game does change, however, as we head back to the moon and then push out towards Mars. So, we look at, what does the science show us? We know it's very difficult. This is probably the one scientific topic that the crew office, both men and women, are highly engaged in. We know it's very difficult to do radiation experiments on the ground. It's very difficult to recreate that spectrum. It's very difficult, when you can only use animals to do scientific experiments, because obviously you can't sit there and irradiate the human. So this is something we follow very closely. Bone loss. Dr. Scott Smith has put out some wonderful articles with his lab. Really, we don't see much of a difference between men and women when it comes to bone loss on orbit. That being said, there are individual and predisposing factors. Everybody is different, and I'll kind of touch on that at the end. One thing we do talk about a lot is, astronaut careers are of varying length, and how well are we taken care of, say, after we leave the agency or retire or move on to a different field. And you heard Dr. Shaw yesterday talk about the TREAT Act, which was authorized by Congress in 2017 to allow us to perform that occupational surveillance after an astronaut leaves the Corps to protect them, similar to the Department of Energy. There are other programs across the federal government that do this. And so this is something that we're continuing to develop. I actually help take part in looking at some of the exams that we do perform on crew members. And so it's actually quite an honor to be able to look at this to make sure we look after our people. And finally, this is my last slide. I kept my slide number short. For those of you who have heard me talk before, I try to tell as much of a story as possible. I have had the great benefit, the great honor of being a flight surgeon first and then transitioning to the astronaut corps. And, as a flight surgeon, you are operating and handling those medical issues from the ground. It's different, utilizes a lot of telemedicine. As Kathy Leaders mentioned yesterday, we've been doing telemedicine for a long time at the agency. And then when you finally get up there, you have a much different perspective. And besides all the medical things we talked about, bone, radiation, urination, menstruation, everything on orbit, you realize how important behavior is, team dynamics, self-care and team care, what we call expeditionary behavior. And Dr. McPhee talked about mixed crews, talked about, the importance of behavior on any sort of exploration class mission. And Dr. J.D. Polk yesterday mentioned that, we look at medical conditions not as an immediate select out sort of criteria. He showed you a big slide of all the conditions we have cleared and waived for spaceflight. And I think when we show that slide, initially people are a little stunned, but you have to realize that this is our job. In the field of aerospace medicine, our job is to keep the person flying as safely as possible, and of course, to protect the mission. And so there needs to be a shift in thinking, and I think NASA has made that shift, that we really don't, again, view medical conditions as select out. We look more as how do we protect that individual against those conditions in spaceflight, what I call personalized precision preventive medicine. Everybody's different. And in order to allow everyone to fly, or at least a chance to fly, that's what you have to look at. Some folks are going to be more at risk from bone loss. So how do you protect that individual? Some folks may be more at risk for GVT. What medications do we provide on orbit? How do we protect that individual? There are things we don't know yet, things that surprise us all the time, and we're not done. So the DVT risk that we discovered not that long ago, there will be other things. And as long as we keep adapting and innovating, then we can get to the point where everybody can have a chance to fly. And so for me, it's exciting because it's like this, not a black box, but being a physician astronaut, you never know what's coming around the corner. And so it was quite an honor to fly, to really look at it from both angles. And so with that, I think I'm almost out of time. I do want to leave a little time for questions and then let people grab their coffee. So we'll stop it there. Again, thanks so much for having me today. I will stop sharing.
Thank you very much, Dr. Non-Chancellor. I think Dr. Schneider is going to be fielding some questions that have popped up.
Yes, once again, thank you for your excellent talk. It's not often that we hear about bodily function, and so we do appreciate that.
Yeah.
In the introduction by Dr. Allen, you seem to have a very strong educational commitment. How do you pass this commitment on to others?
Yeah, thanks, Victor, for asking that. I love teaching. And so part of my job nowadays is to teach residents and students both internal medicine and aerospace medicine. And so I think the best thing I can do as someone in academia, as well as still in the Corps, is spend time as often as possible with those I'm trying to help teach and mentor to become the next generation of physicians, the next generation of scientists, and just trying to spread as much information as possible. I think you get people really excited about spaceflight when you tell them what's going on with spaceflight. I think a lot of folks, there's so much going on in the agency, we get it, commercial space, look at all the science we're going to get from commercial spaceflight participants, even suborbital, looking at all the companies. It's going to open up this burgeoning world of research that we have never seen before. And I think I do a pretty good job of telling a story and getting people excited. And so that's my goal, my husband's goal as well. We love mentoring the next generation of scientists.
Thank you. One of the other fascinating things is that in your educational experience that you were first an engineer before you became a physician and then an astronaut. Can you tell us your thought process on how you decided to go from one to the other?
Yeah, it was interesting because I graduated with a degree in electrical engineering. I loved the way engineering taught you how to think, just the critical thinking, but I also love being around people. And for the life of me, as an undergraduate student, I could not figure out the best way to blend that, but my friends could. And so they encouraged me to enter medical school, to at least give it a shot. And, I will tell you, I was probably not the best ranked applicant. My scores were always kind of average, and I was put on the wait list at a bunch of places. So for all you students out there, think grades and, what someone's initial impression of you does not determine your potential. Your potential is determined by you. And so I loved the way, once I combined that engineering and medicine and then went to work for NASA, one of the first classes I took as a flight surgeon was on the electrical power system for ISS. And I thought, I'm right at home. This is awesome because I understand circuitry and I understand systems. And you have to understand that the human is the most precious system on board the mega system of all systems. But we are a system. We have to integrate with everything else because if one system fails, maybe environmental control or, medical kits, but, countermeasures, that greatly impacts the human. And so when you look at it like that, you realize that we're kind of the pinnacle. The person is the pinnacle, and we have to protect it at all times.
As a crew member on the ISS, you really had multiple jobs. One of obviously was being the medical officer. Could you tell us a little bit about the level of medical facilities on the International Space Station? And are there separate men and women medical care for the International Space Station?
There's no separate care. I mean, we do take into account conditions that can impact maybe men solely or women. And I'll give you an example. So even though you may put a woman on menstrual suppression, there are several cases that very frequently we see something called breakthrough bleeding. And that is very common. We see that on Earth. It's not just related to spaceflight, but you have to be prepared, to treat that. Or if someone happens to have heavier menstrual flow, we have medications to treat that. But in general, the medical kits on board ISS are quite extensive. Honestly, I think we're very spoiled because the ISS has this amazing suite of not only medications and ability to do very small procedures like suturing or putting in an IV. We've got a great ultrasound device. I can draw blood work. And so a lot of times when I give talks, I challenge people to think about how do we miniaturize everything? How do we shrink that kit down? Because we cannot carry the full ISS suite of medical capability to Mars. I just don't think we're going to have the space. So it's always interesting to see if you had to skinny down on your kits, how would that occur?
As a follow-up to that, what level can you do things like CPR on the station? Suturing obviously is minor surgery. Could you take out an appendix if that was necessary? We've all seen movies where that's happened on submarines and other places.
It'd be great if we could. We do not have the capability to do surgery like that, whether open or laparoscopic, on board the ISS for a number of reasons. A lot of papers have been written about this, actually, surgery in space, surgery in microgravity. So we can do very small procedures at this time. And there are a number of reasons why we don't perform surgery at this time. But, 10, 20 years from now, when we have a base on the moon or even a Martian base, do we need to look at that? Absolutely. Could we do something a little simpler to start, like a percutaneous sort of procedure? For those of you in the medical field, you know what I mean, but it's just not something as invasive. But if you had to drain an abscess somewhere or put, something in to provide some level of acute care, you can do CPR on board the ISS. We have the ability to be able to do that. We have a defibrillator, an AED, on board the ISS. Interestingly, when you do CPR in space, you tend to flip your body upside down and you push with your legs on the so-called ceiling on board the ISS. We actually train on this when we get up there. Wish I had a picture I could show you, but it is possible. We try to be prepared for every contingency, but understand that, time to a medical facility, if we have a big event on orbit, is longer than, of course, it would be here on the ground. So we try to plan for that as best as possible.
So I want to thank you very much. Our time has run out. There's more questions, obviously, because your talk suggests that we need to ask a lot of more questions. So thank you so much.
Thank you.
I too want to thank you, Serena. Excellent talk, and we'll be picking on you some more in the future if we do some more on these topics. So don't go away.
Thanks.
Thanks a lot. At this point, we're going to move on to our first panel for the day. This is the panel of Changing Role of Women in Space Exploration, looking at programmatic policy, engineering, and science. Our moderator for this panel is Dr. Julie Robinson. Julie Robinson is Chief Scientist in the Human Exploration Operations Manager acting position in science, technology, and utilization. And she's leading the planning for integration of the science and space technology mission directorates with human spaceflight for Artemis mission to prepare for the first human mission to Mars. And leading is truly the emphasis word there. Julie's doing an amazing job in the integration of all the activities that are necessary for us to be, from a biomedical standpoint, to move on to Mars. She previously spent over 12 years as the International Space Station Program Chief Scientist. So she comes with a wealth of knowledge, a wealth of experience, and a wealth of information to share. So let me turn the panel over to you, Julie.
Well, thanks so much, John. And thank you to all the organizers, to Betty and John and all the others who put so much great time into this amazing and interesting meeting. What I was asked to do for this panel was to coordinate a really broad discussion about the changing role of women in space exploration. Everything from the programmatic, the policy, engineering, and science. And we have a really great panel for you. The way we're going to structure it is each of us is going to make a few remarks. I'll introduce people as they go along, and then we'll have time at the end for just a really nice discussion and to take questions from all of you as well. And I will ask a couple questions along the way just because we want to make this kind of more of a discussion format. So just first to introduce each of our speakers so you're ready to know who's coming. We do have a great panel. After I speak a few words, we'll have Vanessa Weish, and she is the director of NASA's Johnson Space Center. And it's more than 10,000 civil service and contractor employees at NASA. She has a background. She was previously the director of the Exploration, Integration, and Science Directorate. Before that, she was a flight manager of several missions in the Space Shuttle program, and she has also served as an executive officer in the Office of the NASA Administrator. So she brings a real breadth of senior leadership to this conversation. Before joining NASA in 1989, Vanessa worked for the Food and Drug Administration in Washington, D.C. Then we'll hear from Dr. Ed Powers. He serves as the director of the Aerospace Medicine Residency Program at the University of Texas Medical Branch. He's a retired NASA flight surgeon. And one thing that's really exciting is he recently accepted a position as lead mission flight surgeon with Axiom Space. And then finally, we'll hear from Michelle Rucker. She started her engineering career in the Houston oil industry before joining NASA in 1986. She has worked on so many different systems and so many different development and test projects. It's just a wealth of experience at NASA that she's had. She served in the Space Shuttle and the Space Station programs, and she now leads the Human Mars Architecture team, planning for our Moon to Mars architecture, how we'll use the experience we gain on the moon and the systems we develop for the moon to move on to Mars as quickly as possible. So it's a really exciting breadth of folks we have to share with you today. I wanted to start with just a few remarks on my own perspectives on the changing role of women in space exploration. We look around today and we see more women, more people of color, and more LGBTQ plus acceptance and support in our workplace than ever before. That is so important for NASA because it's visible evidence of the progress we've made since the 1970s in ensuring that we fully use the talents of all to achieve NASA's mission. But just because people are in the workplace does not mean our work on diversity, equity, and inclusion is done. When I was an undergraduate student in a pretty conservative part of the country, I remember being one of two women in an organic chemistry lab. And the professor came into the room on the first day of class and made everyone rearrange so that I and the other woman had the lab stations closest to his desk at the front of the class. He said that was because in his experience, women in organic chemistry needed more help than the men, and he didn't want to have to walk around the room to come to us every time we had a question. By the way, I did get the top score in that class at the end of the semester. When I tell this story to young women in STEM today, they're absolutely aghast because that kind of behavior of a professor would be totally unacceptable today. But in that time and in that place, we just shrugged and complied and kind of laughed about it as we walked out of class. So the world has really changed in awareness just in this one generation. And that's an important milestone. My second job working in a lab, in a chemistry lab, the professor told me right up front that I was going to be paid less than the other undergraduate working in the lab who happened to be male. He said that was because he had just gotten married and had more financial obligations. And so he just wanted me to know right away that I was not going to be paid as much. That today we would all see as a violation of Title IX discrimination, and it would be considered illegal. Those kinds of things are definitely not happening anymore. And that makes the world a much better place. But that doesn't mean that we have complete equity in human spaceflight or in science, technology, engineering, and math. When I began as ISS program chief scientist, I was one of only 2 women in the weekly staff meeting, and I was assigned a seat around the edge of the room and not at the table. Now, that wasn't because I was a woman, that was because I was a scientist. And at that point in time, during assembly of the ISS, completing science wasn't viewed as very important, and there weren't enough seats at the table. And so I was asked to sit to the side. Now, later on ISS, after assembly was complete, suddenly people recognized that if we didn't do good science studies on the International Space Station, the program didn't have any reason to continue operating. And then the program manager brought me to sit at his right hand at the head of the table to try and help to change the culture of people who had spent the last 10 years not caring about the science and try and reinforce in them that science was now a really important part of the mission. So it's interesting to see how we do use seats at the table in ways that affect the voices, affect the perception of power or the perception of importance. And that challenge that we faced in ISS a decade ago is going on today in Artemis, because flying a new mission, getting people to and from the moon safely is plenty challenging, and yet we also need to accomplish science there. The presence of greater diversity in our workplace does not mean there's equity of opportunity. And I believe that importance of acknowledging that there are still patterns that influence whether we can achieve the goals of equity, and that the experiences of different people at NASA can be dramatically different based on their gender identity or the color of their skin. I've had the opportunity in my leadership roles at NASA to hear stories of continued discrimination from colleagues of color. For example, a NASA engineer told me about being followed around the local mall by a security guard who thought she was shoplifting, probably because of the color of her skin. That was why that security guard saw that and followed her around. Engaging with another friend, a Mexican-American engineer who had come through an elite engineering program, he talked to me about the experience of being the token Hispanic participant in programs, and his photograph being used while being provided relatively little support in countering different aggressive behaviors that he encountered within the engineering program. And a recent study of science, technology, and engineering math students at Stanford found that women in those programs were dropping out at higher rates than men, because in that hyper-competitive environment, they were losing confidence in their abilities because perhaps of the way that they've been socialized. What I take from these examples is that we have to be very vigilant in our workplace, even as we see the visible signs of greater inclusivity. We have to be vigilant that we are also ensuring an equity of opportunity. And we have to be aware of our biases in language. We have to call them out and reject them when we see them. Social expectations of women and people of color can also be used against them in high-performing organizations like human spaceflight. If one says that a man can be a little hard to work with, listeners can hear it differently, less negatively, without realizing it, than some of the same words said about a female leader. A proportion of people, not everybody hearing these words, might have implicit bias that hold women to higher standards of collaboration and conflict avoidance. So words like these can have disproportionate effects on promotion opportunities and create a negative impression that wasn't even necessarily intended by the speaker. If one says an engineer of color is struggling with a specific task, it may be heard by some listeners as questioning their overall competence in a way that would not be assumed if they are white. So we have to be really aware of our words. Words matter, and they can land differently when they're being said about different people. Even though it may not be intended, words can harm each other. They can harm self-confidence, they can harm productivity, and they can harm the opportunity for promotion. When I was serving as ISS Program Chief Scientist at Johnson Space Center, I often said that I'd found a far more level playing field in my NASA career than I would have experienced had I been in academic research. And I still think that is very true. As I look at the ability of all people at NASA to balance career and family, especially at mid-career when most scientists and engineers are raising their families, NASA and our contractors are really outstanding places to work. I love seeing all the genders taking opportunity for family leave after welcoming a new child, an opportunity that I certainly didn't feel that I had years ago in my career. But we need to acknowledge that the greater trends in our society of discomfort with women in senior leadership positions are still a factor in human spaceflight. I see that more at headquarters, where leadership tasks are more diffuse and roles and responsibilities are less clear than they were at a center. Headquarters roles and leadership skills are often about resolving conflict among different contingents within NASA. We're held accountable for getting things done, yet women are also criticized for not being nice enough while they try to do that. Over the last 5 years, we have had a huge change in senior leadership at NASA, with first women being named to many senior positions, including Earth Science Division, Planetary Science Division, Heliophysics Division, and the Science Mission Directorate. Women have been named directors of most NASA centers over the past few years, including Vanessa, who'll be talking with you next. So I think NASA has made significant progress in promoting women leaders, but the key is, can we make NASA and all of our human spaceflight partner organizations a place that is inclusive of multiple leadership styles without applying preconceived expectations to people on the basis of their gender or race? Beginning the glass ceiling is a beginning, but the next steps are enabling all leaders at all levels to have equal opportunity to apply their talents. And the work at NASA really requires on diverse perspectives in a single mission, whether the perspectives of science, flight operations, and engineering, or valuing all differences in race, gender, and ethnicity. By welcoming a multiplicity of experiences within our own organization and through our partner organizations, from new hires to senior leadership, I think we can continue to strengthen as an organization as leaders in human spaceflight. So thanks so much. And now I would like to let Vanessa make a few remarks of her own. Vanessa, are you ready? JSC Center Director Vanessa Weish.
Awesome. Can you hear me okay?
Yes, you sound great, Vanessa.
Okay, great. Awesome. So first I want to say thank you for inviting me to be a part of the panel and a part of this discussion. I really think this is very important, and just thrilled that it has been organized and to be able to participate. As Julie says, I am currently the Center Director here at NASA's Johnson Space Center. And I myself personally have had quite an amazing career at NASA. I graduated with a master's in bioengineering. So I was fortunate to come and work in what was then called our Life Sciences Projects Division, doing experiments on astronauts to understand how they adapted to space. And had the opportunity to work my way up through the organization, including being in the Space Shuttle program and working with outside providers as they did science on board the Space Shuttle, and actually worked my way up to being a manager of Space Shuttle flights and a part of assembling the International Space Station, which we are currently using today for extensive research. So myself personally, I've seen lots of positive growth within NASA, and from a workforce perspective, external, the community that we are drawing from at the universities, also the increase within diversity in the STEM fields, and the percentages, especially of women that are graduating with STEM degrees. I thought that I would just give some remarks about what has changed for the better over the time of my career. So for me, I will say, again, just the number of women that are in positions today, the number of people of color that have leadership positions at NASA is very different than when I began my career. I can remember being probably around maybe 10% of females in the STEM fields, and I believe across the agency we're probably more at like 35, 40%. For me, I will say that I started in a branch, and I was the first female project engineer, and that hired on as a full-time assignment. And I was very fortunate that my male counterparts were more than willing to be mentors, and I availed them of learning everything that I could from them to be successful in my job. And so for myself, I know that it's very important to feel included when you're in an organization, no matter what the circumstances are. But certainly, if you are in the minority, it's very important to be understood, to be heard, to be given a voice, and to be given a seat at the table. And I've had great mentors throughout the years. Most of them were white males. Earlier in my career, I was fortunate to have people of color that were external to the area that I was in, as well, to talk to about the culture at NASA and how to make sure that I understood what it took to be able to move into leadership positions, and then also to have training that NASA provided that was able to support, to help me to be able to succeed in my career. I do know and support in the fact that NASA just included inclusiveness as our core value, an additional core value. And I think that's very important. You may hear now in the DEI circles the discussion about belonging also in addition to into that. So it's one thing to be on the team, but it's very important to feel like you belong and can come to work every day and bring your authentic self to be a part of the workforce. As was mentioned by Julie, you know, we have had such an increase in the number of females that are in different leadership positions. As a matter of fact, on last month, I was in Huntsville, Alabama, and served on a panel with all of the other female center directors that we have across the agency. And that was the first to be able to have center directors at Kennedy, Marshall, Glenn, and Johnson to be female. In addition, Clayton Turner emceed the panel as a center director of color in addition to that. So that's, you know, a first in NASA history. It does mean a lot for employees to be able to look and see that there are many different types of people in these positions, because it then gives them an idea that themselves could aspire to those roles. When I think about one of the most important things we could do going forward to make spaceflight more inclusive, I do think about the culture that we've set, and making sure that we are both diverse, inclusive, and that we welcome, respect, and connect and engage with our employees. But additionally, before we have employees, we have to have students that aspire to go into STEM fields and that go into college, then proceed to get their degrees. And for those, especially in the sciences, to continue on to getting their PhDs in many cases. I do feel that it's very important that NASA continue with many of the programs that we have in OSTEM and within our human capital with regards to our internships and what we call pathway interns and other internships that we have so that students can have a hands-on experience, which will also inspire them to continue with their education. And then before they go to college and are thinking about college, the programs that we have in our outreach, where we're talking with elementary and middle school students. That's where we really, especially for girls, begin to get the cementing of hey, I can really do this. I can remember being a young girl being in school, and though I didn't have the technology programs that are available today, I was able to do science experiments that got me really hooked. And so doing outreach, we here at NASA's Johnson Space Center have many outreach activities across the community, going into the schools, judging science experiments, participating in helping students build science experiments so they get that fundamental desire of learning. And so making sure that we continue that. In terms of the workforce and how do we make sure that people are aware of the jobs that we have here, the recruiting that we do, how we recruit. Our astronaut corps is more diverse now than ever, but a large part of that has to do with the recruitment that we do. For the 2017 class, I believe we had like 17,000 applicants. And for this last class, which we will be announcing very soon, we had 12,000 applicants. And so that increase of pool then allows us to have a more diverse outcome. And so therefore, while we're talking about Artemis, and when we talk about having for landing on the moon, the first woman and the first person of color, it's because we have recruited and now have those people in the astronaut corps to be able to pull from. So we know that we'll be able to meet that goal. So likewise for the workforce in general, having more innovative ways that we do recruiting, using LinkedIn, and making sure that we use all of our networks to get out to talk to the community such that they're able to understand that there are many jobs, many types of jobs at NASA, and for them to be able to apply then increases the pipeline and then allows us to be able to bring in more individuals. One thing that we're specifically doing as an example at my center and then at other centers as well is to use what we call university envoys. And so we have individuals that are specifically assigned to universities where they're the alumni and go and do reach back into the university to share what opportunities we have, whether it be grant opportunities or internship opportunities, so that we can increase the number of the diversity within our grants and within our workforce. And we do this at all universities, and we have specifically HBCUs, historically Black colleges and universities, that we have alumni from that reach out to those universities as well. We believe that this broadening approach gives us then a larger reach into the community. And of course, those are things that from a center that I do and that we support. But of course, our mission directorates have programs as well. The Science Mission Directorate, the Science Technology Mission Directorate are specifically helping and working with the Minority University Research and Education Project on grants to minority serving institutions to increase the equity there as well. I don't know if I'm over my time, so I don't want to extend into the next person. I do have some other thoughts that I do have from a center director perspective, but I'll hold for now. And Julie, I'll hand it back over to you.
Well, thanks, Vanessa. These are really great remarks. And I think everyone would really like to hear from a center director perspective, what are you doing to increase diversity, equity, and inclusion?
Okay, awesome. Yeah, so at the Johnson Space Center, we've been on a journey, as I would say, for now over 10 years, beginning with previous center directors going back to Mike Coates, and looking at how do we have inclusiveness in the workforce and why we need to have that, from understanding that the diversity of thought, the diversity of experiences, diversity in race allows us to have different ideas brought to the table. So we have included and we have tied together inclusiveness with innovation. And so we've had many opportunities to build and broaden out that concept. One way we do that is through our what we call employee resource groups, and having groups where people can come and they can join together. Some of them are based on affinity. Maybe it's affinity around race, whether it be our African American employee resource group, or Hispanic, or Asian American, Pacific Islander. Those are around affinities. We also have them around also where and what we do. So we also have one that's around human systems integration. We recently just stood up one around environmental sustainability, people that are concerned about the environment around climate change. So it's called GROW. We just stood that one up so that we can get together and talk about solutions to problems, whether it be in the workforce and recruiting, retaining our workforce, and or innovative ideas for ways to improve our center. So that's one thing that we have done. Another is we have what we call Inclusive Leadership Council. And that is a voluntary organization where we have supervisors and we have others get together to talk about being an ally. What does it take to help support individuals that are in our particular organizations? From a white male perspective, being an ally with someone that may be a person of color. How do I share the culture? How do I share what I know about being in NASA and moving up the organization with someone that's new? This inclusive leadership cadre that we have started out with maybe about, I would say, 20, 25 people, and it has grown so that now over 30% of our supervisors are voluntarily members of that, so that they can learn not just from each other, but also outside training to help them to be better leaders. Another thing specifically is, as I mentioned, working on this STEM pipeline, encouraging our employees to go into the schools to help with students. Also encouraging our employees to go back to their universities to share what we're doing so that they are recruiting in a way, and also helping with the grants and other opportunities that are available to the universities that they may not be aware of. And then finally, one of the main or other components is mentoring. And we have an official mentoring program where we pair up individuals that may be at a mid-level with someone that may be senior, and or even if you're interested in mentoring earlier in your career, an early career person with someone that's mid-level. I personally know that for my own self in my career, the benefit that mentoring has played. And so I personally mentor within the Johnson Space Center, other NASA centers, and universities as well. With that, I would just say, our core values of safety, integrity, teamwork, excellence, and inclusion are evident in what we do every day at NASA's Johnson Space Center. And we believe that it's very important for us to make sure that we share that out with others. Thank you, Julie.
No, thank you so much, Vanessa. That was such a great overview of so many things that different organizations can do. Next, we are going to go to Dr. Ed Powers, and I believe for schedule reasons, he is going to be with us via video. So Ricky, if you could go ahead and run that video. I think we're
Hi, I'm
getting
Ed Powers,
the
and I'm
system
presenting Women
readjusted.
as Leaders in Space Medicine, UTMB Aerospace Residency Training. First, I'd like to disclose that my employment changed as of October 2021. I'm now a full-time flight surgeon at Axiom Space, but I'm continuing to work for UTMB part-time as the residency program director. University of Texas Medical Branch of Galveston, or UTMB, has a long history of medical education. The medical school was founded in 1894, and the first medical school classes were held in the old red building. In 1897, Marie de la Landre Dietzel graduated. She was the first woman to graduate from UTMB's medical school. Today, the complex for UTMB is very large. There are over 50 training programs and residencies and fellowships at the university, and many hospitals and clinics, and a great deal of diversity among all the students. So there are only 5 aerospace medicine residency programs in the country. 3 of them are military. There are 2 civilian programs. We have the space medicine focused program at UTMB, and Mayo Clinic also has a program. The history of the program at UTMB began in 1993 when a fellowship was established. And in 1997, the residency program became accredited and it absorbed the Space Medicine Fellowship. So the residency training program has a team here. Myself is Ed Powers, the director. Serena Non-Chancellor is the associate program director, and our program coordinator is Yvette Schultz. For the program mission, it's our mission to prepare physicians in the operational aspects of aerospace medicine and space biomedical research to protect the health of populations exposed to unusual or extreme environments, to be knowledgeable about the physical and engineering aspects of the flight environment, and manage public safety issues from a variety of regulatory agencies. So it's a big course, a big task to fill. We're funded by 3 main sources: the NASA grant, which supplies us with major funding. We have 2 civilian residency slots per year. The NASA funds most of that. We have a very small amount coming from an FAA research grant, and then whatever else we need to fill in, we get from the department funding at UTMB. The curriculum involves 2 years of training. The first year is primarily focused on obtaining a master's in public health degree, which is classroom work, and there are a few months of aerospace medicine clinical rotations involved as well. Completion of a master's in public health degree is required in order to be eligible to sit for the specialty board examinations in aerospace medicine. So the second year is all clinical aerospace medicine and some research. So for the public health degree, master public health degree, there are 5 core courses: epidemiology, biostatistics, health services management, environmental health, and behavioral aspects of health. Those are required in the Masters of Public Health degree. In addition, there are some aerospace medicine specific courses, including toxicology, global health and travel medicine, principles of aviation and space medicine, and accident investigation and risk management. And also a research project is required. It's called the Integrated Learning Experience, or formerly the Capstone Project. It's a mini master's thesis. Clinical rotations that our residents participate in involve a great deal of time at NASA. They spend time at Flight Medicine Clinic, Occupational Medicine Clinic, Neutral Buoyancy Lab. They work with the Behavioral Health Performance Team. They also have some exposure to the Medical Operations Branch, and they also are able to work with the radiation health experts. In addition, there are opportunities to work with commercial space entities such as Spacex, Virgin Galactic, and Space Adventures, and we're currently working on an agreement with Axiom Space. UTMB also is unique. It has a Center for Polar Medical Operations, and it allows us to participate in some of their activities. As a matter of fact, we have a clinical rotation in Antarctica for our residents through the Center of Polar Medical Operations at UTMB. And they serve the National Science Foundation. They man several clinics on the continent. The primary clinic is at McMurdo Station. Our residents spend about a month there in training when the opportunity is available. Other training that they receive in the residency program includes Air Force training. The primary course from the Air Force is taught. They go to Wright-Patterson Air Force Base and get training there. They also get a course in accident investigation and risk from Biodynamics Research Corporation. They also take a travel and tropical medicine course. We also give them the basic AME course from the FAA, and they are able to receive flight training from area airports as well. And they also have the opportunity to become certified in diving to the rescue level. Additional activities include Wings Over Houston Air Show volunteer for the medical tents. There are a variety of research projects. Dr. Richard Jennings sponsors the U.S. Grand Prix and Indy 500 exposure, and they are able to learn about race cars and cockpit protection for occupants. We have a journal club that meets once a month. We have aerospace medicine grand rounds as well. And then when the opportunity arises, they may be able to observe a Soyuz or Virgin Galactic launch. And there also may be an opportunity to do zero-G flights, particularly with research projects. Postgraduate job placement can include being a NASA flight surgeon. There's also a contract with UTMB through KBR, providing NASA support through the Medical Operations Branch, Exploration Medical Capability, or XMC, and the Flight Medicine Occupational Medicine Clinic. There are opportunities for employment with the FAA, the military, some of the commercial space entities, and also we've had graduates go and work for the Mayo Clinic. So as of June 2021, we've had a total of 57 graduates. 41 have employed with NASA or a contractor, 3 with the FAA, 2 with commercial space company, and 3 in some other area of aerospace medicine. So 49 out of the 57, or 86% of our graduates have been employed or were employed in the field of aerospace medicine after graduation. Here's the last 3 graduating classes, 2019, 2020, and 2021. Michelle Hong and Will Valencia just recently graduated. Ann Sung and Amy Krakis the year before that, and then Eric Peterson, Mariah Thompson, and Chris Haas were before that. So since the beginning of the program, we've had 15 women out of our 57 total graduates, 25%. But at the past 3 graduating classes, 4 women out of the 7 graduates were there. So we've had 57% women in our graduating classes in the last 3 years. Leaders and mentors. We've had a number of folks who have been very good leaders and mentors, both male and female, but I want to point out some that are particularly notable. I'll speak a little bit about the women mentors. The first one I would like to mention is Tara Castleberry. She used to be the UTMB Aerospace Medicine Residency Director. I took over her position about 4.5 years ago when she became the Chief Medical Officer at Virgin Galactic. She was not a graduate of our program. She was a Navy flight surgeon, but she has provided a great deal of mentorship particularly for women in our industry. So some UTMB graduates who work as NASA civil servants at the current time are Serena, Non-Chancellor. Of course, we know Serena, she's an astronaut. She's Associate Director of our residency program, and she's also an internist over at Louisiana State University. Shannon Moynihan is Deputy Chief of the Space and Occupational Medicine. And Sharmi Watkins is Assistant Director of Exploration, the Human Health and Performance Directorate, and Mariah Thompson is a flight surgeon, civil servant flight surgeon. There are a number of folks who are graduates that are working under the UTMB KBR NASA Health and Human Performance contract. Natasha Cho is a medical operations flight surgeon. Al Barr is Deputy Element Scientist for Human Health and Countermeasures Element. Becky Blue is supporting primary commercial space support. Ann Sung's medical operations flight surgeons had a few trips to Russia recently in support of that. Amy Krakis is working with the exploration medical capability support. These folks have done a lot more than just these titles, but that basically captures their positions as closely as I can. We have UTMB graduates also working with the commercial space companies. Jen Law is the lead flight surgeon for the next Space Adventures mission, which will be launching next month, December 2021. Natasha Cho, under the contract with KBR, is on loan to Axiom Space. She is the lead flight surgeon for the first Axiom mission named AX-1, which will be launching in February. Michelle Hong is we're also working for Axiom Space. She is the deputy flight surgeon for the AX-1 mission, and she will be the prime flight surgeon for Axiom's second mission. And that will be launching in the fall of 2022, and Peggy Whitson will be the commander of that mission. So in summary, a significant number of women graduates of the UTMB Aerospace Medicine Residency Program are in leadership roles in our field. So the qualifications, number, and diversity of the applicants to the UTMB training program continues to trend upward. It's always a challenge to select only 2 people out of multiple applicants every year. And the opportunities for women as leaders in space medicine continue to increase as the commercial space industry grows. Here's some contact information. We have a website that you can visit. Those are my 2 active email addresses, and you can always contact our coordinator, Yvette Schultz, for more information about the residency program. Thank you very much.
I'm going to jump in here real quick. Julie was having some computer problems. I'm not sure if those have been corrected or not. Julie, if you're out there, just interrupt me. But in the absence of her coming back in, I'd like to introduce Michelle Rucker. Michelle and I have been working sort of with each other for the last couple of years. She has had an incredible role in the Mars architecture planning. She comes with a really great, Julie is saying she's muted and can't unmute. So apologize, Julie, if I'm stealing your position here, but hopefully we can get you around that here in the future.
Oh, I am back. So
there you are.
I am back, but you're doing a great job, John. Just keep going and get Michelle going.
Well, Michelle has done an amazing job with the Mars architecture planning, leading the Mars architecture team. She is also, and I can say this because I've had the pleasure of working across disciplines for a large part of my career. She really does an excellent job of learning medical speak. She got faced with a bunch of these biomedical science and medical folks here a couple of years ago, and she has really done a tremendous job in that regard. But also as an engineer, does a really good job of slowing things down, putting it in simple words, and explaining it for us. So Michelle, go ahead.
Thanks, John. So I've been thinking a lot this week about how the workplace has changed since I first reported for duty at the White Sands Test Facility back in 1986. So back then, everybody smoked cigarettes at their desks, and that's something that just doesn't happen today. So the workplace environment itself has gotten a little bit healthier over that time. I started in a pretty old building that did not have a ladies' room, so I actually did have to go to the building next door to go find the ladies' room. The other thing that has changed a lot over time, back then in 1986, my first office was not very diverse at all. And there was open hostility to changing that status quo, especially towards promoting women in here, even within NASA. I started in the oil industry, and it was actually a little bit even less diverse over there. Coming to NASA, it was a little bit better, but I was a little bit frustrated. So about the early 90s, one day I walked into my supervisor's office, and I drew a line down the middle of his whiteboard. And on one side of the line, I wrote out my accomplishments and achievements. And on the other side of the line, I wrote down one of my male peers' accomplishments and achievements. And we went down the list. In just about every metric, I was running more flight projects. I had published more conference papers. I had more patent disclosures. In each metric, I was outperforming my male peer, except for one metric. There was one metric that he was beating me on, and that was pay grade. He was a pay grade ahead of me and had been for quite some time. So now let me pause this story here and say you should consider this a cautionary tale. I would not recommend that anyone else try this technique, because the last thing my supervisor shouted at me before he tossed me out of his office was that I just scuttled any chance of ever getting a promotion. So from his point of view, he felt he was a pretty fair-minded guy, and here I was coming in showing him data that told a different story. And so he was not very he was not happy about my approach. Here's the thing. In the spaceflight business, we live and die by data. And if the data tells a compelling story, that story gets attention. And so when everybody calmed down, I did eventually get the promotion. And so fast forward to today. Now I have this incredible opportunity to work with the Mars architecture team. We're a cross-agency team. We've got people from just about every field center that work with us. And when I look at our team, it is considerably more diverse than the team I first started with when I first reported for duty at NASA. And that has nothing to do with me. That is thanks to all the supervisors at the field centers in Virginia and Florida and Ohio and California. They have all assigned some of the most creative and talented experts to this team. And so we've brought people together from all across the country. And of course, you can imagine when you bring people together from different backgrounds, humans are tribal, right? We like to draw divisions. And you would think that those divisions would be by portions of the country. On our team, I'm not going to lie, we have had some tribal boundaries. There was a dispute about whether the University of Texas shade of orange or the University of Tennessee shade of orange was superior on the color wheel. But at the end of the day, the only color that matters on my team is the red planet. And what's interesting about our team is we are all Martians. It doesn't matter where we're from, where we went to school, what our backgrounds are, whether we're doctors or scientists, because we've got both. What matters is that we are Martians. And so to kind of sum up here, sort of 3 big takeaways for me. The first is, if you are patient and you have the perspective of a little bit of time, you can see that things do change. If you are like me and you're not so patient and you want to try to push change, my advice is bring data. Bring data and be prepared to stand behind it, because data is really what counts in this business. And what that means is when your supervisor asks you to take a survey or to collect metrics, don't roll your eyes. That is an important data collecting tool, and it will help the change that you would like to see. It will help implement that. And then the third thing, I think this is really important. Again, humans tend to be tribal. We like to find divisions, even if there aren't any natural divisions. We like to make up our own. But what we've found on our team is that the mission itself, the mission is what's so important, and that can become your tribe, if you will. And it can overcome a lot of the social divisions that society at large tends to accept. Within our team, we are all Martians, and for us, that worked. And so, Julie, I'll turn it back over to you now.
Thanks so much, Michelle. When we were preparing and talking about this panel, you mentioned to me that sometimes you believe it can actually be an advantage to be a woman in the workplace. Could you talk more about that? And do you think that's still true today as much as it was when you were earlier in your career?
So I'm not sure I would say it's an advantage as much as bias. We have to recognize that bias cuts both ways. Let me give you an example of that. When I was a senior in college, we all had to go take the engineer and training exams, one of those licensing things. And the night before the exam, we were all reminded that in the history of our university, only 4 people had ever failed that exam, and they were all women. And that was a horrible message to tell the women, but in thinking about it, it was even worse for the men. As much pressure as I felt that put on me, it had to have just been so much worse for any guy in my class who was thinking, well, I'm going to be shamed not just for not passing this test, but what it says about me and my social status. And so I think we have to recognize that bias. Sometimes different groups of people will hear the same bias and interpret it differently. I started working as an intern student in the oil industry before I came to NASA, and I had a male intern student colleague whenever he would go down to the machine shop, the blue collar machinist would tell him they couldn't get to his job until next week. And then from their perspective, he was kind of this, he was an MIT student. He was kind of this, young buck coming in, making them feel like he was looking down on them. My supervisor at the time noticed that whenever he sent me to the machine shop, the machinist would stop what they were doing and work my job. So it was an advantage in that situation over my male colleague. I'm not saying it's fair. I'm just saying that it cuts both ways, and I think we sometimes get wrapped up in our own perspectives and our own grievances. We don't always recognize that these things do cut both ways, and we have to be conscious of how everyone in our group is reacting to certain situations.
Yeah, thanks, Michelle. And I want to invite people who are listening to start putting some questions in the panel. We'll start addressing them. I thought it was great that you used that AIT example, Michelle, because a really seminal study in STEM education dealing with high school girls found that if they told a set of high school girls and boys that an exam was hard, the women performed less well on the exam, and the men didn't have any effect. So the control group, women and men equally competent, but if you told the girls the exam was hard, they didn't perform as well. So there is so much about what's in your head and what is communicated, and that really does affect performance of different groups in scientific studies. Let's see. I think I wanted to get all my panel members to go ahead and turn on their videos. So we'll do our best in this virtual environment to have a bit of a conversation with everyone. And let's see. And Vanessa, do you have any reactions or responses or thoughts to some of the things that have been said since you spoke while we're waiting for questions from the audience?
Yeah, no, I want to express Michelle some of the things that she was mentioning. I was just sitting smiling, remembering the early days and what it was like of, like you said, being one of the few women that were in certain jobs and roles, and knowing, Michelle, that yes, we had the same qualifications, but yet we're not being given the same opportunities, right? And commend you for the courage of going and putting it on the whiteboard and saying, and I know Michelle very well, and so I know she did that just that way. But I will say, so fast forward to where we are today, right? It is up to each of us to speak our truths and to stand up for ourselves, whether it's when we're in college, in academia, and or in the workplace, being able and willing to go forward and saying, I am qualified for these positions. Julie, and there's another study with regards to women and applying for jobs and being turned down and not applying ever again. But, I will just say, you have to have that courage. You have to have that, hey, I didn't get it this time, but I'm going to go dust myself off, figure it out, and go back the next time.
An interesting time in an organization is when an organization is under pressure, such as when things are really substantially changing. And that produces a level of competition between employees, a level of uncertainty. Vanessa, what are your thoughts about ensuring equity and inclusion in a change management environment? Is that different than in our regular day-to-day work?
Well, so for me, I believe that we have to always be in a changing environment, right? Because we're never going to get out of the status quo or where we are today unless we're always pushing forward. So I see the need for always thinking about how we're going to include others, how we're going to get this, as Michelle talked about this Martian team where we have all these different thoughts come together. That's to me a day-to-day. That is my day-to-day. And so always thinking about and including the path for us to be able to bring in others is just a part of the game. So I don't see it as being more different because that's my status quo.
Yeah, thanks for that. You know, Michelle, one thing you talked about is kind of personal style. And, you know, what are your thoughts about what is expected of women in the workplace? I'm sure, like, I bet all three of us here have been told to be nicer at some point in our life. And those are kind of just really recently recognized as being pretty loaded words that are used differently again to women employees than they are to male employees. So what are some thoughts about that?
So let's just admit it. As ladies, we've all been called names in the workplace. My policy has always been, you can call me whatever you want, as long as the word competent is in front of it. Any slur you want to use, it doesn't bother me as long as I'm competent. And as long as, you know, and to some extent, I think it's incumbent on us, on everyone really, to make sure that you try to maintain competency, that you don't get caught up in you know, just trying to get promoted for the sake of getting promoted, and trying to move into jobs that maybe you're not quite ready for yet. It is important to you know, to take the time that it takes to make sure that you can do the job well, because nothing will set you back quicker than moving into a job that you can't do well, and then you sort of tarnish your own reputation. So I've always been I've just made it a point to make sure that I spend the time it takes to get good at the thing that I've been assigned to do. And I try not to worry too much. I know in spite of my story where I was pushing for a promotion, I try not to push to move into a job that I'm not ready for. And I think that we have to recognize that. And sometimes it's important for supervisors to say, I know you want to go to this job, but here's the background and the training and the experience that we're going to need to help you get before we're ready to move you to that job.
Yeah, I'll add to that. I completely agree. When I think about lessons learned for sharing with others, that's the first thing, right? Is you got to be technically competent. But I will also say with your question about how we're told to behave, I will say that at the same time, we have to have confidence, right? In order for us to do those jobs. And we have to have courage because yes, you know, we are, there's a double standard of how we present ourselves versus our male counterparts. And so therefore it comes with that loaded language that you mentioned. You know, I will share that I was leading a very large team in the shuttle program. And as you said, we're about our mission, right? We all know what the objective is. And so for me, I was like making sure laying out, this is what the job is, this is what we have to do, and what the roles are. And I was told by someone, you're being mean. And I was, what? I'm being mean? I'm being clear, you know, but sometimes you have to understand how others perceive that, right? And so just making sure that what I see as being clarity is truly that, right? And then I'm not being one or the other. But, you know, but you do have to sometimes remind yourself there is a double standard, right? And not to fall into that trap. I agree.
In our last couple of minutes, I want to take one question out of the audience, asking about, you know, did the agency create a committee that's kind of working on or approving initiatives towards increasing equality? And I think approval would not be the word I would certainly use from the interactions I've had with those groups at NASA. But Vanessa, you may be able to comment on that a little more from a cross-agency perspective.
Whether or not there's a committee that approves.
Yeah, a committee that can help all departments accomplish diversity and equity, and who's head of it and who would approve those initiatives.
Oh, okay, okay. There is a focus on with this mission equity, and there is a lead. So I would say each of us are responsible at our particular centers, right, for making sure that we have appropriate diversity, equity, and inclusion initiatives. And as for me at our center, for example, I have a Innovation and Inclusion Council, and I have the associate director leads that. I am a sponsor on that particular council, and I make sure that all of the different initiatives are done. From an agency perspective, we then share out what we're doing at each of our centers so that we can understand best practices and learn from each other.
Great. Well, I want to thank all of my panel and of course, Dr. Powers as well for the preparation to participate with us. Michelle and Vanessa, it's been great having this conversation with you. And I hope that it was a valuable contribution to the meeting. And thank you again to the organizers and to all my panelists.
Thanks, Julie.
Thanks so much.
Thanks, Julie, and all the panel. That was excellent. We actually move on now to our next panel, which is Human Factors and Human Systems Integration Evolution, which is sort of a nice bridge between conversations we've heard earlier in the day and now of how we integrate. Serena had mentioned that the human is the most challenging and the most important system involved here as far as human space exploration. So with that, I'm going to turn this over to Dr. Robert Howard. Dr. Howard is the Habitability Domain Lead in the Human Systems Engineering and Integration Division at NASA Johnson Space Center. He's provided human factors and habitability expertise for a variety of NASA exploration programs and study teams, including the Orion, Gateway, Lunar Terrain Vehicle, Pressurized Rover, Surface Habitat, Mars Transit Habitat, and Mars Ascent Vehicle. Dr. Howard, it's your turn to present and lead your panel.
Good morning. I am trying to get my video going. I think you see me now. So thank you very much. And we are looking forward to a very exciting panel. I'll be starting first, and then I'll be transitioning to each of my panel members in turn. Are you sharing my slides, or should I bring mine up?
You can go ahead and bring them up.
Okay. Let me load my slides right quick. Almost there. Give me a quick second for PowerPoint to load on me. It's taking its time. Almost there. Okay, now let me share my screen. Okay, hopefully you're seeing me now. Let me get started. And
Dr. Howard, excuse me for interrupting. We can see your slide, but I cannot see the interpreter, and I'm not sure about others.
I will take care of that.
Okay, thank you. Go ahead, Dr. Howard.
okay. Let me get started. And I'm kind of going to personalize this. When I was given the topic of spaceflight for everybody, I thought, wait a minute, that includes everybody. So if it's for everyone, then I think it should be for me too. We heard talks this morning about genders, talks about races, nationalities. I don't know if anyone spoke about ages yet, but all ages, all body types, all medical conditions. If spaceflight's for everybody, should be for everyone, and that includes me. Personally, I've always wanted to go to space. I want to go to Earth orbit. I want to go to the moon. I want to go to Mars. I want to go to Venus. But I want it to be just like traveling normally. I want it to be something where there is no health screening. It's just like getting on an airplane. I want it to be something affordable that I can buy a ticket on my salary. I don't have to be super rich. I don't have to finance. I can just book from it's affordable to where I can just pay. And I want it to be a normal standard of living. This has no relevance to current events, but I want there to be good food up there. I want there to be good bathrooms, good recreations, good senses of accomplishment, and good fulfillment. We're not there today. We know spaceflight today is just for a small number of people, and we're just beginning to see it move from government astronauts to private citizens. And where I work today, since I don't get to go into space, I help design vehicles. I work on Michelle's Mars architecture team, as well as several other teams. My focus is human factors. We look a lot about the anthropometric ranges. And what we do is we have a database that's based on the US Army. In the old days, we used to talk about percentiles and say we're designing for the 95th percentile male. We've gone away from that now to just translate that into minimum and maximum values. Usually the minimum value is associated with the female and the maximum value is associated with the male, but that's not the case for all body dimensions. There are a couple of body dimensions where that's reversed. But we try to make sure that the vehicle can accommodate the range of astronauts that we expect to fly. And that's a challenge sometimes. We have to enforce those rules with the design teams. Sometimes the designer will say, do we really have to design to this full range? Can we just limit the population design to maybe the 50th percentile and below? And the answer is no. It was no back then. And as we're moving towards opening spaceflight for more people, it's even a bigger no. And when we talk about the idea of spaceflight for everybody and moving beyond NASA into the general public, then the ranges need to expand beyond the Army database and include the global population. So of course, you know that the general public is much larger than the military public. We need to consider gender effects, the urinals, you heard earlier about menstruation as an issue. We need to allow for all of those things. We need to allow for privacy. When it's sort of the good old boys astronauts club, it's like, we don't need privacy. We're close. We can just tough it out. But when you start saying we want the entire public, we want the world to be able to go into space, we need to think about real privacy. It's not just a nice to have. It's something that's really important for the mental well-being. That's an ongoing challenge we've got to incorporate and convince the engineers that allocating the mass, allocating the volume for that is part of why we're going into space. Now, in order to get the vehicle design right, whether it's our current designs or future designs, we use a combination of physical mock-ups. We'll use virtual reality. We'll conduct simulated missions in either of those environments to help us make sure we've got the right vehicle before we even start to cut any metal on the flight vehicle. So where are we right now? What are the things we're trying to build? There are a number of vehicles you can see in this picture. I'm only going to focus on the ones that the crews live in. So you see in the foreground the Unpressurized Rover or the Lunar Terrain Vehicle. I'm not going to talk that one for this talk because it's not a habitat, but there are human factors concerns for that vehicle. Instead, I'm going to focus on the Pressurized Rover, the surface habitat, and the transit habitat. So the Pressurized Rover is sort of our mobile hab. It's a huge benefit over what we had in the Apollo program. If you've seen images of the Apollo, looks like a dune buggy. We still need unpressurized rovers, but the pressurized rover offers you something tremendous. This lets you live in this vehicle for a short duration, allowing you to travel further away from your base or for your lander. The whole idea is we want to explore parts of the surface that are further away from our infrastructure than we can walk to and from. It gives us a comfortable environment to live and work when you're not doing a spacewalk. Gives you good physical recovery in between. When we took these to the desert and did field testing, we actually compared them against an unpressurized rover. And we saw that benefit between the different exploration sites. They were able to rest and they were in better condition than the counterparts in the unpressurized vehicles. The pictures you see up there are the first generation prototypes. We're working on our third generation design now, and we're partnering with international partners to help make that vehicle become real. The surface habitat is the outpost we're going to put on the moon. It's intended for 2 crew to possibly as many as 4 crew. And it's got more advanced or more capable features than what you'll have in the rovers. We've got medical facilities, exercise, a galley, crew quarters, stowage capabilities, maintenance and repair capabilities. It's intended for 30 days. There's talk of increasing that to 60, and we'll see how that goes. You could go a little bit further than 60 in this tab, but if you're talking a year, then that's a different vehicle than what we're working on right now. This is just for sort of the Skylab durations, 30 days, maybe a little bit more. It has its own power generation. It can even recharge some of the surface vehicles, so the rovers could come up to it and plug in to recharge. It's sort of a communications hub for talking to Gateway or talking back to Earth. The idea is this vehicle would have a 15-year lifetime, and we could use it over and over as we go to the moon. We're working with industry partners to develop this vehicle. Now the Transit Hab, that's our vehicle to go to Mars. This is the long duration vehicle. We'll be in this vehicle for anywhere from, depending on mission architectures, the shortest one I've seen is like 700 days, the longest one's like 1,200, but right now we're in this 800 to 960 range. You've got a long travel time from Earth to get to Mars. The architectures we're looking at now, we're only in Mars orbit for a short period of time. So we're minimizing the surface stay time. So this vehicle will sit in Mars orbit for about 50 days, and then it's about 17 months to go back to Earth. Those durations change a little bit when you change what year you're talking about because of the trajectories between Earth and Mars, but it's in that basic ballpark. It's a 4-person crew. It's set up for everything they're going to need to keep the habitat up and running and for them to do their mission. So all of your subsystems, the interfaces to monitor them, your repair capability to fix whatever's broken. You can control your course, your navigation, perform daily housekeeping. You'll do outreach to the public back on Earth. You'll do your exercise, medical capabilities. You'll train. You'll conduct science on this vehicle. They cruise between Earth and Mars. It's such a long period that I think of it as a separate mission. So you're going to do science on the way to Mars and on the way back. You may even conduct astronomical observations. You'll study the effect of the deep space environment. We're going to be concerned about that on humans. We're also going to be concerned about on vehicle systems. We may even have other science payloads where we want to monitor how does being out in deep space affect them. Once we reach Mars, 2 crew will stay on board this hab and they'll continue to work from there. The other 2 will go down to the surface. So that's what we're doing now. But the public is starting to get involved as well. We have private spaceflight emerging, and I'm sure most of you have been following this news. Virgin Galactic was the first on the stage with their July 11th launch. The favorite to me is when Captain Kirk flew. And that was symbolic, one, because I grew up watching Star Trek, but it was also significant because we had a participant who was clearly outside of NASA's medical standards. And that's the thing about spaceflight for everybody. I'm excited about the potential to see more than just this narrow range of the human population going into space. So we need the commercial industry to start flying people who don't fit what has traditionally been a NASA astronaut. We want to see more and more people of different types go into space. SpaceX had their Inspiration 4 flight. That flight was notable to me because there was an actual raffle associated with the donations to St. Jude's. So people who can't afford to go into space, there was a chance to fly. I spent a couple $100 on lottery tickets myself and didn't win, but at least I had a chance to try. SpaceX is preparing their Dear Moon flight, which is going to circumnavigate the moon. They got 1 million applicants. Again, I was one of them. I'm going to keep trying until I get there one way or another. But you've seen recently news for commercial LEO platforms, so that's even more exciting. You're starting to see companies saying, we have the capability, we're going to put something in space. NASA's going to be a tenant, other people are going to be a tenant, they're going to be tourists. It's going to transform what it means when you think about spaceflight. Now, all of these are habitats, even the ones, the suborbital vehicles where the crew is in there for just a few hours. People were living in those vehicles. And the designers innovated in ways that you don't see in NASA vehicles. Spaceship Two had a crew seating that was kind of unique to them. New Shepard has a capsule where they intentionally created a large volume. And I could tell just by looking at it, it was designed to enhance the experience for the crew members that were on aboard that flight. It gave them a lot of room to move around the cockpit. Dragon had that cupola, and that was an amazing view. That was really a unique development. We've got a cupola on the space station, but the one that they flew on Dragon was really innovative. And then you've heard the news about the space stations that are coming up. One of them is featuring something called a single-person spacecraft. It's basically it's not a spacesuit, but it's a little small cabin that one person can get in, and it's like they're going on EVA. That's going to allow tourists, general public, people who are not trained, to go out and do their own version of a spacewalk. So all of these are providing more opportunities for people to go into space. It's still not spaceflight for everybody, though. The costs have come way, way, way down before people like you and I can afford to book our own flights. I think LEO, though, is going to create an opportunity. I'm calling it habitats for everybody. It's more than just NASA replacing our space station with a new NASA space station. We'll be one customer there, but we won't be the only thing going on by a long shot. Just go to Google and look up space stations and commercial space stations. You'll see all sorts of concepts that are out there. My hope is that in my lifetime, I'll be able to go to somewhere in LEO and visit it as a private citizen. That's my personal goal. And I think together we can move towards the day where everybody can visit the moon, can visit Mars, and go to other locations in the inner solar system. I don't think it's just the moon and Mars. I think there are lots of other places that we would want to be able to go. And with that, I believe I'll turn it to our next person, which is Sudhakar Rajlu, who's going to be talking about extravehicular activity suit evolution. So with that, Sudhakar, ball's in your court.
Thank you, Robert. Can you see my charts yet?
You can go ahead and share your screen at this time.
Can you see it now?
Yep, we see it.
Okay. Thank you, Robert, and good morning to everybody. Robert is a very inspirational speaker, and he makes it almost like space travel is really exciting and wonderful, which is, in my opinion, I share the same enthusiasm, but the reality of the space is still a hazardous environment. Once we leave the Earth atmosphere, what we are dealing with is lack of oxygen, very little atmospheric pressure, extreme temperatures, and of course, radiation. The reality of space is that humans, all of us, have very little chance of surviving without complete protection. We have made tremendous advances in launching vehicles that are safe to travel. And with recent commercial vehicle participation, we are making that more and more of a safer travel. Unfortunately, there are instances that even during launch and re-entry, we humans need additional protection. And when Robert talks about going to Mars, on the moon, and using the habitat, he doesn't it doesn't portray what needs to happen when you go outside the habitat. We need protection because of all this lack of things that are essential for our survival. So whether during launch or re-entry, or as well as working outside of the vehicle during an orbit, or as well as on the moon or the Mars, such as the planet such as Mars, we require protection from the hazardous conditions of the space. And that is what a spacesuit provides. So in addition to launch vehicles, we do need spacesuit, which itself is a system on its own, because it provides protection as well as water, oxygen, and temperature control, as well as monitoring capabilities to make sure that the humans are safe and sound. And when we talk about spacesuits that are protective for humans, there are three different types. One is the launch and entry suit. The one that you see, SpaceX or Blue Origin, it's slightly different than the one NASA uses. Yeah, I'll show you a picture of that later on. And then there is a microgravity suit where you don't need much of a leg mobility, but you do need much more articulation for your shoulder and arms. And then the planetary spacesuit, which would require us to perform locomotion so that we can move from place to place. Now, let me give you a background of how NASA has evolved since 1960s, but I want to make a disclaimer very quickly. I am not a suit engineer, so I apologize that I'm speaking about suits because there are many, many great engineers in the suit engineering department who can talk more about all these things. My role as a human factors engineer is to make sure the spacesuit accommodates and includes all humans. So starting with the Mercury, at that time, NASA was concerned that is it possible to send a human into space and orbit the Earth and then come back and return safely, and both the vehicle and the human. And that was the purpose of the spacesuit at that time. And it's kind of like a launch and entry suit. It was adapted from Navy Mark IV flight suit. The only difference was the flight suit was open loop, whereas the suit that was used during Mercury program was a closed loop breathing system. And one thing when we talk about, say, spacesuit, and we need to remember how it all started with for whom. NASA only recruited from a pool of exclusively male military pilots. And these are all very heavily trained and skilled human beings. And those are the ones NASA deemed worthy of risking their lives to test out whether we can orbit the Earth. And there was also a height limit, 5 feet 11 inches was the selection height limit, because that was the small size that could fit into the Mercury capsule. Now, after the success of Mercury program, NASA then got into what we call the Gemini program. And this is the first time NASA attempted to experiment with EVAs, which is extra vehicular activity, which means the crew would not just be cooped up in the vehicle, but they would be venturing outside the vehicle. And the purpose of that was to prepare us for landing on the moon and performing our manual explorations there. But for that, before that to happen, NASA wanted to make sure that the suit will survive the exposure to space environment. And also they wanted to perform other activities like docking and also rendezvousing with the another vehicle and all those things through having crew members outside the confines of the vehicle. As you can see, even though the suits were customized for the military pilots, and then some adjustments were available for sizing in arms and legs, the EVA activity was minimal. And also they noticed that the suit was very difficult to operate and work with, and that limited their ability to perform many other activities that they had planned originally. So there were a lot of challenges at that time, but still the success of that program led to what we call the Apollo program, during which time NASA had already procured the new suit, the Apollo A7LB, that is the lunar walking suit, which we have seen astronauts walking on the moon. And it was also custom made for the specific crew members. But even then, even though it was custom made, there were a lot of issues with the suit. There were interferences with some of the body parts of the crew member. They have to custom make some of the, make adjustments to the helmet. And so in general, NASA was still learning and evolving all the suits as we are progressing. In spite of all the accomplishment they were able to make with what they were designing at that time. So when NASA, after the Apollo program switched into the space shuttle program, one thing they decided to do was open up the composition of the crew members. Now the crew members are more diverse, and they included both the males and females. And also they realized that they have to make some changes to how they design the spacesuits. Now the picture that you see here is the launch and entry suit. This is the one that the crew members use during launch and re-entry. And so given the huge expansion of the sizes and shapes of the crew population, NASA had to take a different approach. Rather than customizing the suits, what NASA was able to do was make them separable components so that they can be swapped out, to allow resizing and customization so that each crew member can have the flexibility of getting into a certain limited sizes of the suit components. And as you can see, since 1980s, NASA was able to utilize the EVA suit to build the space station, launch Hubble Space Telescope, retrieve the telescope and repair it, has done so many other things. And one of the major accomplishments for NASA was on October 18th of 2019, 2 women successfully completed an EVA task that has never been done before. So NASA was able to not only increase the diversity of the population, but also trust and enable the EVA to be performed by all women. And that was a major accomplishment for NASA, which happened very recently. Now, after the space shuttle was retired, NASA took on a different program, and that is to create a spacesuit that would attempt to accommodate even wider range of body shapes and sizes. One thing I want to mention here is that though space shuttle EVA was performed by both males and females, and also all female team, the existing sizes were limiting some of the small sized males and females. And NASA wanted to make a change to that situation by increasing the overall range and accommodation. And the new suit also will have advanced mobility features because NASA is planning to go to the moon as well as to Mars. So in this time, what NASA was able to do that was using 3D models of the human body very early in the process of design so that we can confirm the sizes and the shapes of the hardware would meet the needs of accommodating the wide range of population. And once that was done, NASA was able to conduct functional testing in 3D printed mockups so that we know for sure that now that the suit will not only accommodate the various ranges of people, but also will enable them to perform the tasks that are deemed necessary with the EVA suits. So, in conclusion, we started off this spacesuit program in 1960 with Gemini EVA, which is very, very limited and very restricted to a few select humans, male population. Now, what we have is a highly capable system that can accommodate a large portion of the population. But bear in mind, we still, as Robert was talking about, it's a very restrictive military population. And the hope is that, so how do we expand so that we accommodate not just the military, but general population, but also there are other categories of accommodation that would be in the future, would be considered in as we improve our design. So that is how NASA has evolved in terms of not only building the vehicle, but also making sure that we go into space and perform and work as well as live in space. So that is my end of my presentation.
Thank you much, Dr. Rajalu. And now we'll hear from Dr. Rich Williams, who will talk with us about the Rosetta Stone for space exploration. Dr. Williams, it's all yours.
Good morning, Dr. Howard. I'm going to go ahead and share my screen here. Okay, so thanks for giving me the chance to talk at this meeting. I really appreciate it. I'm going to start with an apology. I'm worked for about 19 years in NASA, but I retired 4 years ago. I didn't have the good sense to stay retired. I went ahead and signed up to do a public health job and as a public health director in Virginia. So my past 4 years have been very remote from space medicine. So some of the images, as well as during this presentation, may be a little bit dated, but hopefully still relevant. If anybody's interested, I can tell you that the pandemic has been one of the hardest things I've ever had to do, and has certainly taken a big toll on the healthcare infrastructure. So this project really had its genesis early on in my career with NASA. I was detailed as an Air Force officer, and I was serving as Deputy Chief Health and Medical Officer at that point in time, but functional equivalent of that in the late 90s. And early on, I went to senior NASA officials to identify issues, and went to the senior engineering folks and so on and so forth. And I was generally met with polite and sometimes not so polite skepticism coming from medicine and life sciences. Similar experiences were happening all over the agency. Had a lot of discussions with senior leadership at JSC in the medical world. And so we all realized that we needed to evolve our communication. And we started on a journey at that point in time that is still going on. The reason for all that is kind of multifactorial, but communication is the key. So, we decided to work on that over the years. And during my last year in NASA, in talking with the technical authorities, we decided this was worthy of some further study. So they commissioned a team of multidisciplinary experts to kind of examine this. And what we produced is the Rosetta Stone manuscript. We named it the Rosetta Stone with a nod to history. The Rosetta Stone was discovered by Napoleon's forces in Egypt during his campaign there in the early 19th century. And like most of the rest of the history of the world, it's ended up in the British Museum. But
Excuse me, Dr. Williams, we're not seeing your
yes.
slides at this time?
You're not?
No.
Okay, I'm sorry.
I can share them for you if you'd like.
Yeah, please do. I think that's probably what we'll have to do. I'm connected to WebEx by the browser, and possibly, I'm seeing them for sure in the web application or in the WebEx presentation, but why don't you go ahead and share them and advance to the slide that says the Rosetta Stone.
I take it you mean not the title slot. Yeah, there you go.
Stand by. I think I failed to. All right, I think I've got it now. Let's see if, am I now effectively sharing my screen?
Well, I've got it shared for you.
Okay, good. No worries then. All right. So, so the Rosetta Stone, of course, was the key to hieroglyphic translation for early scholars in the early 19th century, containing a script about Ptolemy, both in hieroglyphics, Demotic, which was the language of common Egyptians, and ancient Greek. So with a nod to history, we named it the Rosetta Stone. Next slide, please. So human systems integration is always critical. The industries, multiple industries, are replete with examinations of human systems with examples of human systems integration failures. They are always embarrassing, often always costly, and often dangerous. So getting human systems integration right as best we can, and it's a multicultural, multidisciplinary enterprise to do that. It's very important. And I would submit that in this day and age of space flight, where we're going to have passengers and enhanced passengers and people who are medically potentially compromised go into space, it's more important than ever to get this right. Next slide, please. So about the time I was getting ready to leave NASA, Craig Kundrat produced this slide, which I deeply appreciated at the time and still do, highlighting the differences between the way engineers, life sciences, and medical folks actually approach what we do. We actually approach it from opposite directions. Engineers design their systems. We try to reverse engineer systems that are existing that we are trying to understand. So that is one fundamental difference that leads to often to a whole different set communication methodologies and cultural differences between engineering and life sciences and medicine. Next slide, please. And speaking of medicine, aerospace medicine, as it has evolved, has some problems at its core. My first career was as a general surgeon. The first half of my medical career, I worked in that arena. As a surgeon, I generally enjoyed great trust with my patients. They needed me desperately to get over whatever the problem was they had. It was a very pure relationship. In aerospace medicine, we in NASA and the military, we do function as the medical docs for the crew, they're responsible for crew health. But there's also a regulatory component. And the image there in the lower right is from an article written by David St. George recently about some of the deep issues that occur during the aviation medical certification process. So in that sense, because we do have a regulatory responsibility in flight medicine, we are to some extent a threat to crew, and that is only overcome by a dent of great effort and trust. But over the last 100 years, that's caused us to be painted with a certain brush, and I think that sort of bled off into life sciences as well, and we all got sort of like I said, painted with the same brush. So that's another dynamic that needed to be or needs to be kept in mind and overcome. Next slide, please. Again, this is an image from 4 years ago, but I think it's a very useful image that reflects our thinking at the time, which I think still prevails, of characterizing our enterprise in human health and performance as considering the spaceflight environment and evolving through the understanding the hazards, gathering evidence about human health with regard to the hazards, and taking a risk-based approach controlled by standards and requirements, which engineers can understand very well. That's what they live by in engineering program management, resulting in mitigation. So this is the construct we evolved. And once we started down this road, which we did over a long period of time, I think we started to enjoy more success. Next slide, please. That's another image from that time, but it simply demonstrates the different elements of human health and performance in the agency: the Office of the Chief Health and Medical Officer, the level 1 crew health and safety folks, human research program folks, and the flight medicine folks, all integrating in a standards, risk-based, standards-based mitigation producing approach to relate to the human spaceflight programs. Next slide, please. And this is a framework that engineering folks can understand and relate well to. So when we talked to the technical authorities and they sort of commissioned this study to be done over the course of a year, which we did, we got together a multidisciplinary team from science, engineering, and medicine. We had human factors folks, we had space medicine folks, we had behavioral health folks, some straight engineering and safety folks, and we all got together and we talked this over. We sort of created writing assignments for exploration and to produce chapters, and we ended up with the Rosetta Stone manuscript. Next slide, please. That's simply a list of the chapters. At the end of the day, we ended up with some observations. We first and foremost, we recognize that the roles and relationships between the project and the technical authorities and the folks relating to the project always will generate an atmosphere of dynamic tension. That can be and that's multifactorial. Again, costs and schedules will factor into that. The whole political climate factors into that. The technical authority work factors into that. But there is a tension. It all occurs in a dynamic tension environment, which in its best expression can be positive because it brings out the best of us. But it can also be very destructive. And then between all the disciplines trying to come together in care of the human, in human systems integration, there are cultural differences from the substrate we work on to the way we do our jobs, to our method, our communication and lexicon, and even the way we train. There are differences there. and resulting in the fact that left alone, the communities don't understand each other very well. Not like we do people from our own community. That again has overlay from the aeromedical relationship that we discussed. Human nature factors into that, as we've seen in our general population over the past couple of years, can certainly have some off-nominal influence. This principle of developers versus operators, very, very important. You can't just develop a complex system and hand it off to the operators. Developers have to have investment and accountability and responsibility for this, just like the operators do through all mission phases. So that's a principle that needs to be observed as sort of a sacred thing. And then there are many techniques that are shared despite our differences between different disciplines. Next slide, please. So we generated a bunch of recommendations. Many of these are actually being done and have been engaged within NASA over the past years. Certainly, we all realize that cultural differences exist, and we have, I think, collaboratively striven or within each community to understand ourselves better. And I think the agency is better off certainly now than it was during my years, as far as I can tell. We need to understand and actually going forward engage these differences early in the career path of practitioners that we know are going to be going into the human spaceflight industry. A lot better if we start early in this. Needed to develop common lexicon and means of communication. Practically what that meant was that the medical and life sciences folks began to learn to speak engineering and communicate in the engineering paradigm. And I think that's an evolving skill set, but we're doing that. The imperatives that all members of these very diverse communities, that sheet's really to the last recommendations about leadership, which we'll get to in a minute. And again, addressing the dynamic tension. Next slide, please. We thought this was worthy of further study going forward. So at some point, it probably would still be a good idea to engage the national academies to take a look at this, probably all three of them, especially as the commercial human spaceflight industry grows, and we end up sending more and more folks that are naive to the space environment, not trained to the extent of crew, yet they are in the operational environment and intimate contact with systems and crew. This probably becomes more imperative going forward. I think this whole disparate ways in which human factors and HSI are organized and addressed throughout NASA, I think been a lot of progress in that, and I think we're marching down that road. The agency is pretty well. And everybody should be responsible in every phase of the program, including operations. And we did develop in those years, based on National Academy recommendations, an ethics-based decision framework for addressing extraordinarily high risk in human spaceflight and human health in spaceflight. And that methodology might be considered for other really high extraordinary risks going forward in exploration missions. Next slide, please. And the last thing we recognize is this really is a leadership responsibility from the very top. So effective HSI should always be a priority for the leadership of the agency and industry. And all these communications and pathways and collaborations should be ensured as a fundamental leadership responsibility. That's the end of my presentation, sir.
Thank you very much, Dr. Williams. We will go next to Dr. Suzanne Bell. We may be sliding a little bit into your lunch, but I hope everyone can stick around. Dr. Bell, it is all yours.
Hello, thank you for having me. I'm just going to share my slides here. Ooh. All right, can you see everything okay?
We can.
Great, thank you. Okay, the most recent astronaut class is diverse in professional background, military background, race, ethnicity, and sex. Astronauts today are far more diverse than the Mercury and Apollo era, as you've been hearing, but they have at least one thing in common. In fact, they have it in common with astronauts selected during the Mercury and Apollo eras as well. None of them have been astronauts before. Astronaut candidate qualifications are about ensuring astronauts have the right competencies or potential, and then they train extensively to learn the job. Today, one of those critical competencies for which they're selected and trained is teamwork. Teamwork is central to the astronaut role. Astronauts work together to conduct research and perform everyday tasks. Astronauts also team with mission control back on Earth to complete procedures, problem solve, and conduct complex feats like spacewalks. Sometimes astronauts even team with non-humans. Future-oriented job analyses of the astronaut role show that teamwork will be even more important for future space exploration. Unlike the relatively large ISS with its multiple modules, for Artemis missions, the crews will live and work together in a small space the size of a studio apartment. In later Artemis missions, there will likely be high workloads with repeated EVAs to the lunar surface. The crew will have access to mission control with limited delay. However, Artemis will be an important proving ground for mission to Mars. A mission to Mars will absolutely challenge the limits of human collaboration. Teamwork will be complicated. The crew of 4 or maybe 6 will be confined to a space the size of a small studio apartment now for something like an estimated 2.5 years. As the crew travels further into deep space, the extreme distance will result in significant communication delays with Earth, up to 22 minutes one way. Complex feats such as landing and launch from Mars will be executed by the small crew with unparalleled levels of autonomy from ground control. The crew, composed of members diverse in multiple ways, such as professional background, national background, and sex, will need to work together as a team. They'll need to rely on one another for social support, keep interpersonal conflicts manageable, coordinate seamlessly to execute complex tasks, and adapt to whatever comes their way. The Human Research Program captures the potential impact that the hazards of spaceflight may have on team functioning and the possibility that this could lead to behavioral health and performance decrements as the team risk. Research is conducted in analog environments to characterize and develop countermeasures to mitigate the team risk. To date, much of the team risk research has focused on isolated and confined environments. Research has been conducted in natural analogs such as teams stationed in Antarctica and chamber simulation studies such as the Human Exploration Research Analog, or HERA, at Johnson Space Center. While the team risk is relatively newer risk for NASA, research is already starting to inform the mitigation strategy. In my short time with you, I'd like to highlight the importance of interpersonal relationships and isolation confinement and reimagining the relations between crew and mission control. Interpersonal relationships is a central theme for teams that live and work together in long-term isolation and confinement. Teams are different than the sum of their parts. Even with extensive selection, training, and astronauts being well-intended, there are still some reports of degradations in social functioning in spaceflight. Conflicts in long-term isolation confinement seem to be inevitable. Conflicts are reported in astronaut diaries, even in the relatively shorter 6-month flights in the ISS. Astronauts report more conflicts in the second half of their mission. Likewise, a data mining review of analog teams in isolation and confinement showed that some teams were more variable than others in the number of conflict incidents per month, while others are more stable. Some teams report conflict early on, while others do not. But by 90 days, or 40% of the mission complete, all missions reported conflict either within the crew or with mission control. A similar result was observed in more recent analysis of 5 4-person crews isolated and confined for up to 45 days. Crews had unique patterns of conflict in terms of amount, type, and timing. Concept mapping of open-ended analog data suggests 4 types of conflicts: noted discords, work disagreements, interpersonal tensions, and interpersonal breakdowns. Noted discords were disagreements that tend to be noted but dismissed. For example, bad behavior being attributed to not enough sleep. On the other hand, interpersonal breakdowns were more severe and marked with intense aggravation, high emotion, and relationship toxicity. Because conflict's inevitable, effective conflict management is key. Astronauts go through conflict management training as well as other related trainings. Recent analog research lends insight, however, to how other countermeasures such as workload management can also contribute to effective conflict management. Conflict was related to strain in a study of 9 4-person analog teams in isolation for up to 45 days. Workload had an important role in the weakening conflict strain spirals over time. Current day conflict was associated with next day strain when next day workload was high, but less so when workload was low. Workload management, such as recovery periods, can not only help with fatigue management as currently used, but can also help mitigate conflict strain spirals that can occur over time in isolation and confinement. Not only can interpersonal relationships affect an individual's strain, a failure in unit level social integration can also have substantial effects on the team's ability to perform. Team cohesion is an attraction to the team and its tasks. It can be a source of social support and motivation in teams. In general, astronauts often report cohesive relations in their diaries, such as this excerpt. Commander and rookie crewmates were great. We all helped each other and made it through these 2 days. However, astronaut diaries also show a trend of decreasing positive comments about group interaction over time. While many teams can maintain cohesion over time, subgrouping, where a subset of team members bond without bonding to the crew as a whole, and the presence of an isolate, where someone is alienated or withdraws from the team, are two problems that have been noted in both spaceflight and analogs. Anecdotal evidence has suggested that subgrouping and alienation can form around values, personality traits, and biodemographic variables such as national background and sex. In some of our recent work, we collected data on interpersonal relationships and team performance at multiple time points from 9 4-person teams in isolation and confinement for up to 45 days. Our results showed expected performance improvements on an operationally relevant team task over time when the teams were cohesive, but not when an isolate was present. In practical terms, while some cohesive crews were able to meet 100% of their assigned objectives, when crews had an isolate present, they were only able to complete up to 50% of the mission objectives. Research continues characterizing this risk, how we might monitor it in spaceflight, as well as understanding the factors that might contribute to failures in crew cohesion. One such effort has been work by Contractor and colleagues, in which we create a predictive model of team composition for future space exploration. In this line of research, we use computational modeling parameterized on analog data to predict how well different combinations of people work together over time. Importantly, we were able to predict relations and deploy a countermeasure in which crews were paired on scheduled tasks as a means of repairing strained relationships. Just like personalized medicine, these predictive models can lend insights into optimal and timely countermeasures based on the team's composition. Just as relations between crew members are important, relationships with those back home, whether family or mission control, are important as well. Research to date has mostly focused on communication and relations between the crew and mission control. This figure was generated as part of a data mining review of analog research in isolation and confinement, and shows the average commander to mission control report length over time for crews in isolation for up to 240 days. Written communication decreased over the course of all 3 long analog missions. Gushn et al. Describes this as the closing of a communication channel, or psychological closing. Psychological closing can include a decrease of the communication volume throughout isolation, decrease in the issues discussed, and preference for communication partners. Not only might there be psychological closing, but significant communication delays will likely require a fundamental shift in crew-ground relations. When you watch spacewalks on NASA TV, the interdependence between mission control and the crew is clear. Communication is a constant interaction between the two. As crews journey further from Earth, communication delays will increase. Research introduced a 50-second comm delay manipulation in a small study of 3 astronauts and 18 support staff on the ground. Results showed no differences in self-report performance, but increases in stress, frustration, reduced efficiency, and decreased situational awareness. As one astronaut in the study put it, things you could do independently were fine. Things where you relied on the ground resulted in lost time and lots of frustration, which is just not going to work. Significant work is underway to understand how autonomous crews can be most effective as part of the team risk and also part of the human systems integration architecture risk. Our goal is to characterize the risks as diverse individuals come together to do something greater than a lone person could ever do, and to provide the countermeasures that can help these teams to go the distance. Thank you.
Thank you very much, Dr. Bell. Our final presenter is our agency's lead in human factors, who I've had the pleasure of working with for several years. And Dr. Cynthia Null, it's all yours. Cynthia, you're muted. Still can't hear you.
Find the control.
Okay, we can hear you now.
Oh, thank you. So I'm going to talk about how human systems integration is evolving at NASA. As you all know, so I don't really need to repeat, this is done in the context of human spaceflight, where the missions are human endeavors. They are complex systems. We've talked about the extreme environments, and mission lengths can be anything from hours to decades. As Kathy Leaders, Dr. Chandler, and others have stated, humans are key. Humans provide the adaptive capacity to shore up these systems, dealing with everything from everyday routine disturbances to unanticipated and potentially catastrophic crises. HSI is an approach to focus on all mission elements. And I will note that we have just published a new handbook for how to implement HSI in NASA missions, not just human spaceflight, but others in aeronautics as well. So our definition of human systems integration is that it's a required interdisciplinary integration of the human as an element of a system to ensure that humans, hardware, software components cooperate, coordinate, communicate effectively to successfully form a specific function or mission. Our perspective is that you don't develop or create a technology and then find a human that can operate it. You find out what the human needs are and then develop the mission around those so that the missions can be successful regardless of what happens in the environment or with the mission components. Human systems integration is based on scientific research on human capabilities and how humans work and live, interact with one another. The data we're talking about is about all human capabilities, how we work in teams, as was just discussed, as individuals within complex environments, and with technologies. Everything needs to be understood. Our physiology, our perception, how we walk, how we eye-hand coordination, problem solving, responding to unexpected events, how we work with others, and how we work with technology, all of that. A key here is collaboration, and HSI has a variety of tools and processes that enable that are applied across the entire life cycle of a mission, from the original concept, understanding what is needed to meet mission goals, for all, and what the responsibilities are for hardware, software, and humans, through to the retirement of the mission. As I mentioned, humans are key to every mission, whether it's a crewed human spaceflight mission or something that will be called uncrewed, which is not a mission without people, they're just not on board. Everything in a mission has the potential to influence or be influenced by the humans, and HSI considers all human roles across the mission life cycle, starting with designing for small tools to mission architecture. Even drawings, electrical, structural, can be critical. Even the design can be correct. If the drawings are wrong, it might be manufactured to the drawing and not to the intent. Testing, our test facilities start with testing parts and get to the system level. We worry about manufacturing, workflow, logistics. Are the parts there when we need them? How do we move the elements until we can integrate them into a complete system? Maintenance, transportation, operations, teamwork, communications, and again, how to respond to the unexpected. To be successful, missions must take advantage of the unique capabilities of humans to be flexible, creative, adaptable, resilient, and to solve problems. Let me give you a couple of examples. So this is one of the things that we find is when we imagine how things are going to happen, like we think about our vacation or we think about processing the shuttle, we have this ideal notion of what the processing is going to be like. In the beginning, we thought the shuttle would fly 2 or 3 times a month, and that turnaround would be sort of like pulling an airplane up to a gate at an airport, not taking it into a major overhaul facility. The actual inter-flight processing looked like the image below. We focus, although we had the agency had this notion of quick turnaround, they focused in the design on vehicle performance, which was absolutely critical. But in the process of focusing on vehicle performance, they didn't think through all of the tasks that would have to be done to maintain the vehicle. So there wasn't always access, hatches weren't in the right place, sometimes major systems had to be removed to the one that was going to be repaired more or maintained more often. So it was similar to a car I once had where you nearly had to lift the engine to replace the fan belt because it wasn't easy to access. Those weren't the only problems, but by focusing on the performance, we got an amazing vehicle, but that didn't mean that it was going to be easy to process. The military had a similar problem in a sort of a much less complicated vehicle, but still not simple. And that was a helicopter. And they'd been using helicopters for a long time, of course. And when they went to make a new helicopter, this is several years ago, they looked at the current helicopter and realized that it needed 134 different tools to do standard maintenance of the engine. And so they actually created a contractual requirement that the new engine would not take any additional maintenance skills, but it would also require fewer maintainers. And how they accomplished this was actually using an HSI tool to analyze the tasks, the tools, the training, access, so forth. And in the end, they developed an engine that could be maintained using 6 tools. The tasks were less complex, they required less time, and there were fewer mechanics. So by focusing, they also got the engine performance they needed, but by making that a requirement and focusing on that, they were able to reduce the maintenance time as well as tools. Let me give you an aerospace example. Now, this is slightly different because this is a situation where we actually designed a restraint system to be used in this window that met the astronauts' needs. But notice you don't see a restraint system in this picture. So although they did the analysis and built a really effective restraint system, it was not manifest at a time to support operational timeline. That's NASA speak for the restraint system was at KSC while the persons on the ISS were having to do tasks around this window. To take a picture, you actually need a camera to be stabilized. So there is a handhold actually under the camera that you can see right here, and the camera is attached to it for stability. You can't take time-lapsed photos by just telling the person to hold still. To stay in position so the astronaut could actually get the picture of what they needed, they sometimes had to hold on. And right over here above this gentleman's head is a flex hose that is responsible for keeping this window properly pressurized. On occasion, the astronauts would grab onto that to maintain their stability because there was very little else they could grab onto, such as the very delicate camera. And over time, the flex hose actually became loose and we ended up with a leak on ISS. This was found after a couple of days of search. It was repaired. They then put a cover over this so that the astronauts couldn't use it as a handhold. And eventually the restraint system was delivered on time, but didn't match up with the task needs. But not everything we deal with in human systems integration is just about hardware or fit or those kind of things. It's often about the information that we have. This is an example of from the grounding of a cruise ship called the Royal Majesty. This particular grounding was a much more complex event. I'm just going to talk about one aspect of that, and that is the location information. What you have here is lat long and speed, and also a display which gives you the path. This is the dredged area where the ship is supposed to go. And you actually have the spot of the current spot of the vehicle, and then a projected outline of if they stay on this course where they'll end up. And of course, they were expected to turn at some point. Now, what actually happened was that the crew was very excited to have this new ship, this new capability, because they now had accuracy for where they were in the ocean, much more than they'd ever had by having a brand new GPS system. And so this accuracy was just welcomed, right? However, on this particular day, the GPS had become disconnected. But these are what the displays look like, even though the GPS was disconnected. Notice that lat and long and speed and the angle of the ship's trajectory are given with a lot of accuracy. By the time this grounding happened, this display continued to show the estimated location of the ship. The location of the ship was actually 17 miles away from where the display said it was. So by now, the crew was supposed to notice two things on this display: an acronym DR and an abbreviation SOL, which actually told it that the display was making estimates instead of using the GPS. But there was no strong indication, such as no GPS. And the accuracy of the estimates, or the precision of the estimates, did not change, even though their accuracy had changed. So by keeping the precision on this display, it allowed the crew to think that they were actually getting very accurate information. It was precise, but very, very wrong. Human systems integration relies on diverse disciplines and domains to bring together knowledge of human capabilities as applied to mission design and operations. As we've stated, HSI considers human capabilities across all areas, and it also worries about the change in capabilities over time. As been mentioned before, sometimes we get some sort of degradation of crew capability in flight, for example. It can also happen in the ground with things like sleep deprivation or reduced sleep, interrupted sleep. It could be loss of bone and muscle, all sorts of things, even for us, one day to the next change. And human systems integration is interested in trying to understand those changes and trying to accommodate them. HSI is obviously a very collaborative domain, and it's built on the knowledge from many scientific disciplines, engineering and safety domains. Human system principles are key to enabling human spaceflight for everyone. Focusing on human needs, the knowledge and approach and the tools of HSI will continue to open human spaceflight for everyone. And thank you very much.
Thank you much. We'll take questions now until we run out of time and we're kind of kicked off the stage.
Dr. Howard, we're beyond the time that we had initially established, but if there are a couple of burning questions, why don't we address those if the audience is willing to stick around for a little bit? We do have a lunch break after this So it's eating at people's lunch or dinner or breakfast, depending upon where they are. But if there are a couple burning questions, if you have, or if Dr. Schneider has come up with a question or two.
There are a couple of questions that for additional, for more than one person to answer.
And
And this is
could all the
really,
panelists put their cameras on? I'm sorry.
and so really for Dr. Howard and Dr. Bell is, are there design steps that are built into habitat vehicles for behavioral health issues? That is, example for teaming support and things like that?
We'll usually use what we call analog missions to try to understand some of the crew dynamics. And that's basically where we will simulate a day in the life or days in the life of a particular crew mission. And we'll use a representative mock-up for that habitat. That can help us to uncover how the crew needs to interact together. For instance, we would do that in the desert. We call it desert rats. You can Google some of the things about that, where we would simulate with the rover in particular. We were looking at how do the astronaut crews work together with the ground science teams and with mission control in order to do geologic surveys. We did something similar with the habitat outposts, where we're also looking at how does the crew work together. So we try to use that before we get to the requirement stage to try to figure out how the crew needs to work and how the hab needs to be designed to accommodate the crew.
And as a complement to what Dr. Howard's saying, we also collect specifically the behavioral health and performance impacts on things like habitability. So looking at different areas of a habitat and how it's used and how that affects feelings of privacy or engagement with others. And so we do systematically collect that data with a measure called SHAC that was created in our lab by Lauren Landon and some other folks. As just one example. But yes, definitely, we definitely look at these types of aspects of the habitat.
Thank you. Dr. Williams, in your talk, you highlighted the different scientific languages that each discipline uses. Do you think that what will eventually be needed is formal courses to be developed and required for individuals that work across discipline lines?
Thanks for the question, Dr. Schneider. I don't know if, well, yeah, I think if people can identify early on in their career that they want to venture into a collaborative industry where human systems integration is so critically important. I mean, it could be space flight. I mean, all industries where humans are involved in travel as operators and crew and passengers, as Cynthia Null just said, or need this desperately, right? So yeah, I think including these principles and the imperative for effective communication in curricula for engineering schools, if you will, and even medical schools, and then in space life sciences and other scientific curricula that are applicable, I think it'd be a great idea. Certainly cognizance is imperative for anybody entering the field to achieve the optimum level of collaboration in the across the entire spectrum of human and systems integration.
Thank you. Dr. Rajulu, this is a maybe a loaded question, but is it possible for NASA to build spacesuits for the individual? I mean, tailored design for each person?
Well, it's possible. The only question that comes about is the cost of maintaining an individually customized suit is currently very costly, prohibitive, and that is one of the reasons that NASA is choosing to make it more what do you call modularized suit components. And currently, I mean, if you're looking at all the missions that are planned, we are talking about few crew members, and with the mixing of men and women being part of the team. So we need to be concerned about the weight of the additional spare parts. So In the future, I see that becoming a more reality, but right now, the way the suit architecture is, it's much more makes sense to make it more modularized and not customizable.
Thank you. Dr. Knoll, one of the things that you mentioned was the difference between perhaps robotic and human spaceflight missions. And I was wondering if there were any differences in the HSI approach for these different types of missions.
Well, sort of yes and no. Yes, in that you may have fewer humans, right? In the science or robotic missions, the humans are usually not in extreme environments, and so that some of the concerns you have are different. But understanding what the jobs are and how to get the missions right, so that they can be successful, how you deal with communication, team communication, how you deal with off-nominal events, how you deal with the distance between the vehicles, and like was talked about by Dr. Bell about just the complexity of having communications and control at long distances. A lot of those things are quite similar, but the size of an HSI approach could be quite different. With the humans being not on the vehicle, but there still are many critical roles for humans throughout the life cycle for both missions, both types of missions.
Thank you. There are many more questions, but because of the late hour, I'm going to stop asking the questions now. So thank you, John.
Yeah, thank you, everyone. Thank you very much to our plenary speaker. Thank you so much for all the panelists today. Up to this break, it's not over yet. They've been really excellent. We are scheduled to rejoin back at 12:35. Apologize, that's a little bit shorter break than anticipated. There have been some questions about is the session being recorded? If so, when's it going to be available? We have some information for that. I think we'll be able to probably put that up on the screen during the break so that you'll be able to find out where to access that from the first day. And then as each day goes through, there'll be links to where to access the presentations as the recordings of those. So again, thank you very much. Thank you to our interpreters for their awesome job that they've been doing today and yesterday. And thank you to all the presenters and the audience. We'll see you back at 12:35 Eastern. Thank you.
No, 1:35 Eastern.
Oh.
1:30 Eastern.
Yep, thank you.
Thank you.
Dr. Van Balen, I assume you're on. I can't see your name here, but.
I am on, John.
Okay, just a couple of comments before we get started, Dr. Van Balen, just to the group. First off, thank you all for joining us again here at 1:30. I apologize for that error when we went to break, and thank you, Dr. Schneider, for correcting me. That's why we're a team. I just wanted to reiterate that Ricky had posted on the slide when we were at break that there is a website where individuals can go to the recordings from yesterday. There will be another posting for recordings from today. We'll make sure that those are available by posting them, certainly, as you can see them as participation in the group, but also we'll make sure that it's clear tomorrow where that will be accessible once the symposium is over. And for those who may not have been on earlier, we you probably catch from that we are recording each of the sessions or the entire sessions so that they will be available. If you also, a reminder, if you have questions and answers as we go along through the panel this afternoon, if you'll put those in the Q&A block down at the bottom of your screen. And with that, let me turn this over to Dr. Van Balen. Dr. Mary Van Balen is the acting assistant director of human system. Actually, I'm sorry, Mary, you are the director now, right? Human system risk management at the Johnson Space Center. You can correct me later. As such, she manages the weekly Human System Risk Board, or the HSRB. The HSRB identifies high-value risk mitigation targets that capture areas where there are major gaps in knowledge or capability, and other targets that support risk reduction that may be addressed by interested stakeholders, such as HRP, the Human Research Program. In addition, she has responsibility for the lifetime surveillance of astronaut health, or the LSAH, about which you heard a good deal of that yesterday. So at this point, it's my pleasure to introduce Dr. Van Balen for this next panel.
Thank you, John. I appreciate that. And good afternoon, all. One of the things that I want to do is let our panel just a little bit this afternoon. My understanding is that James Paterini is unable to be with us due to some constraints from the Crew 3 launch. Many of the list about NASA's commitment to mission, and we're actually seeing that with James. James is unfortunately disappointed to not be able to be here, but he is focusing on NASA's mission at this point. Appreciate that with him. We do have a strong group of speakers to talk. We'll have Sharmi Watkins, who is the Assistant Director within the Health for Exploration and Health and Human Performance Directorate. Dave Francisco will talk about risks and standards as well. He is a technical fellow with the Office of Chief Health and Medical Officer. And then we'll have Steve Platts talking about in his role as the Chief Scientist, talking about upcoming research for exploration program. And I will round it out with NASA's way of thinking about, I hope you guys find this interesting, and I will turn it over to Sharmi.
Thank you, Mary. All right, let me get started here. Perfect. And I'm going to share my slides. Just give me one moment. All right, is everybody able to see that?
Yes, Sharmi.
Wonderful. All right, everybody. Well, thanks for having me today. I am going to start out the panel just by giving you a little bit of overview information. I'm going to start by talking about the hazards that I think have been discussed in some prior sessions, talk about the human system risks, and then the phases along the way, the opportunities we had to mitigate those risks. All right. Here you see 5 icons that represent the hazards of spaceflight, and they're sitting in low Earth orbit. And I wanted to start with them there today because that's really where we have the bulk of our human spaceflight experience. And I think you've been hearing that throughout the sessions today. So these icons were created by the HRP communications team. So I wanted to thank them for letting me use the icons in the presentation today. This first one in yellow represents distance from Earth. And for our experience so far in low Earth orbit, we're pretty comfortable 250 miles from Earth. And that gives several advantages, one of which is the almost minimal or insignificant delay in communications. We also have the opportunity for frequent resupplies, and we have the opportunity to give things like fresh food and bonus packages to the crew from a psychological benefit. If we ever needed to, in the event of a medical emergency, we could be back on the Earth in a time measured in hours, which is very important. Now, the second icon here is the one in black with the astronaut. It's being tugged on by Mars and the Earth, and that represents different gravitational adaptations. And so for a typical mission to low Earth orbit, there's the first adaptation to microgravity, and then followed at the end of the mission by an adaptation to 1G. You see an icon in blue that's an astronaut that she is being subjected to radiation. And as you know, in low Earth orbit, we're relatively protected from the effects of radiation by Earth's magnetic field. You see an icon in purple that represents an astronaut living in isolation and confinement. And that confinement now is on the International Space Station, which is equivalent in size roughly to a 5-bedroom home. And finally, there's an icon there in green that represents the closed environment. And that closed environment of the space station is surrounded by the hostile vacuum of space. And there's a very delicate balance of life support systems within the closed system. As we think about leaving low Earth orbit to go other places, to the moon, to Mars, wherever that may be, these hazards are still going to be present, but they change a little bit in their quality. So as we leave, the distance from Earth is going to increase. And with increasing distance from Earth is going to come some communication delay, different depending on our different locations, and also potentially some periods of communication blackout. Those things that we talked about, like bonus packages or fresh food or unexpired medication, those are going to be harder to send during the mission, so I'll have to plan correctly and pre-position those. Now, there's also that return to Earth in the event of a medical emergency. And here we're not going to measure it in hours, but rather in days in the case of the moon, and potentially weeks or months when we start to think about Mars. Then when we talk about gravitational adaptations, there are multiple now. So you have the transit to a different location like the moon. You have the partial gravity experience on the surface, and then another adaptation to microgravity before you have the 1G adaptation on return to Earth. From a radiation perspective, we'll leave that relative protection of Earth's magnetic fields and we'll head out to the deep space environment. And the isolation and confinement won't be in our 5-bedroom home equivalent, but something the size of a studio apartment. And finally, we'll have multiple closed environments to contend with. So in the case of our Artemis missions, we have Orion, the gateway, the landers, and the suits. And we may have yet other elements of the architecture to think about. So the reason we talked about these hazards is just to set the context for the human system risks. Because I think by understanding those risks, then we can think about the mitigation strategies. And that's what our panel would like to chat about with you today. So we take those hazards away and we'll bring them back. Let me reveal for you the human system risks that are derived from each of them. So derived from the risk of isolation and confinement, we have 2 risks. So I'm sorry, derived from the hazard of isolation and confinement, 2 risks. One that's on a team level and one on the individual level. We have 4 more human system risks that are related to that increasing distance from Earth and the increased need for autonomy. Then we have 2 more risks related to radiation. One is the in-mission risk of ionizing radiation, non-ionizing radiation, and then the later term risk of radiation carcinogenesis, or the risk of developing a cancer as the result of radiation exposure. 12 more that have to do with that change in gravitational gradients, whether that's to microgravity or partial gravity. And I won't talk about each of these in detail, but you get a sense here that some have to do with body loading, some have to do with fluid shifts, etc. And there are 11 more that are related to that closed environment. So the balance of life support that we talked about before, making sure that there's enough oxygen or not too much CO2, and toxic exposure is another good example, the things that we may bring with us in the form of propellants or payloads. So as a set, Those are the human system risks that we've identified and that we talk about as a crew health and performance community. And the reason we talk about them is it's important to understand for each of these, not only the pathophysiology and the genesis of the risk, but the likelihood and the consequence and the mitigation strategies that we can bring to bear for future missions. So within the HSRB, or that Human System Risk Board that Dr. Van Valen chairs, we talk about each of these. We think about the likelihood and consequence, and we use a scale to rate them, a 5x5 matrix. The result of that is a color code, which we use to talk conversationally about these. So I will show you, if we looked at these in the context of a mission to the moon, a short duration mission, and we applied the color code we use within the HSRB, it would look like this. And rather than spend any detailed time talking about each of them or the color codes, I just wanted you to look at the landscape. And you get a sense that there are some green, some yellow, some red, reflecting the likelihood and consequence of each. Now, if we shuffle these up and look at them again for a longer duration Mars mission and apply the color codes, you see a different landscape. And I think you see that we have challenges ahead of us in terms of the crew health and performance systems to address a Mars mission, to make sure that we really brought down those risks to the fullest extent possible. So where are the opportunities to do that? We talked about the hazards and we identified the risks, which is the first step. And we try to dig really deep to understand why the risks are occurring. What are the mechanisms at play? Then we go on to research and technology development to further understand, to look at these things in analog environments, for example, and to develop mitigations that we can use on different missions. We also work closely with strategy and architecture teams. We work with them to figure out what we can interject into those conversations. Can we help with the orbit selection? Can we help with landing site selection so that we are designing the mission to be the most conducive to human health and performance? And then in design and development, we're working all the time with the vehicle designers, making sure they understand our human system standards and that they're designing the vehicle with that right oxygen content, the right CO2 content, right pressures, right countermeasures, et cetera. And so that's a very close collaboration. But additionally, across the top there, you see that we're also working to make sure that the human is fully optimized for the mission. And so that is done through selection and certification of astronauts for a given mission. And then in the operations realm, we still have opportunities to ensure that crew health and performance are at the forefront. So we can make real-time operational decisions as well, taking a day of rest between two strenuous EVAs, for example. And then finally, because we're a learning organization, we're learning at each step along the way, and we're feeding that information back to inform not only the human system risks, but each of the other steps along the way. And that's all I have for you in terms of introduction. I believe I'm going to pass back to Mary, and we'll take questions at the end.
Thanks, Sharmi. I hope everybody's enjoyed your talk. I always like when you talk it because you laid this out in a way that gives us a good understanding of how risks are framed within the agency and how the agency then goes to manage it. And our next speakers in this panel are going to talk the standards and the research and the evidence base. And then I'm going to end with, here's how we manage and think about these risks. I always think it's a nice stage to set it. So thank you.
Thank you.
The next speaker on our lineup is Dave Francisco.
Hey, Mary. I'll share my screen. All right, hopefully you can see my screen.
We can, Dave.
Perfect. All right, so as Sharmi mentioned, I'll be covering our standards, and this includes both medical and performance standards. And just give you a background from a NASA point of what we consider a standard is what we give to a program. So think of like, the lunar lander program or even our commercial crew program. We generate what we call program requirements. So think of a contract. If you're building, your own personal house, you tell your contractor, this is how I want the house built, and this is how it needs to be built safely. This is how it needs to be built so the human can survive in it. So that's what these standards are used for. And this is where, as we say, the rubber really hits the road when this is how we implement all those risk mitigation techniques that Sharmi talked about and things you've heard over the last couple of days, how we protect the crew, and how we ensure that everybody is safe and that we have a successful mission. So the standards that we call out for these are like our human spaceflight standards, and they're called NASA Standard 3001. And there's a website at the top of this. And if you just search NASA and the word OCHMO, which is Office Chief Health and Medical Officer, a website should pop up. And if you go to the standards portion, everything I'm talking about is on that public website. So if you want to access these documents, take a look at them, and for your own use, they're all publicly available on that website. And this is just a graphic to show you everything that's in these standards. There's over 800 different standards in there that cover everything from spacecraft system design from a human perspective. So we're not covering the structural aspects. Those are covered in other NASA standards, but we are covering what are the dynamic loads that are imparted to a crew member. How do we ensure a crew member lands back on Earth safely, lands on the moon safely? What kind of seats are put in place? All those types of things are in there. How big of a habitat do you talk about? As Sharmi mentioned, International Space Station is the size of a 5-person or 5-bedroom home. What if you're in a smaller capsule? What's the minimum amount of space you need to be able to perform the functions you need to perform? How automated is that vehicle? How does the crew interact with that automation? How do you ensure that the crew can perform a manual control of something if they need to take over, if something that's automated fails? Displays, controls, shielding for radiation. We have guidelines in there that protect for solar particle events. What guidelines, what do you need to protect for? How much shielding material do you bring? What's the probability of the event occurring? I think Sharmi also mentioned environmental levels, making sure we have the right oxygen levels, carbon dioxide levels. Realize you're in a closed environment, basically on Earth, if you're in a building, it's a closed environment, but you're still getting outside air in. But once you're in a vehicle, everything that's in that vehicle, that crew member is breathing, they're breathing out, that has to be scrubbed. So you have to make sure you have the adequate levels so the crew member can perform and stay healthy. The other thing we have is protecting health outcomes. We have standards in there that say, what is the minimum aerobic capacity you need to perform an EVA in microgravity or on a lunar surface? How much bone loss is acceptable? I call, we're accepting risk on every one of these. Ideally, you have no bone loss. And we've tried to minimize that over the 2 decades we've been on space station. We've gotten better at it, but we still experience bone loss. And we have to make sure that we have adequate countermeasures. And by countermeasures, I'm talking about exercise hardware. Our research programs have also done testing on anti-resorptives for bone loss. So there's a number of options that are available. But these standards contain all the minimum of what we expect systems to be put in place to protect a crew member so they can exercise, so they minimize bone loss, muscle loss, maintain their aerobic capacity, maintain their muscle strength and conditioning so they can go do EVAs, and also to maintain their health from a cardiovascular point of view. And we have some like we call performance bands that fit in there where we say, hey, you could lose a certain amount, but if you want to do an EVA on a lunar surface, you go below a certain level, the performance is going to be severely degraded. So we want to make sure, one, that we're protecting health outcomes and also protecting performance outcomes. Medical conditions, we cover a medical system, what requirements are required, what you need to bring from a pharmaceutical standpoint, diagnostic hardware, all those requirements are in here. So that kind of gives you an overview of all the different standards and requirements that are in these documents. Once again, there's over 800 of them, so there's a lot of material to digest. So one of the things we've done is we've developed what we call technical briefs, and they take a lot of these standards and they integrate it, and each one of these technical briefs basically provides you an overview of the standard, background information of where that information came from, give you reference data, and then it'll give you how to apply the standard. So you can look across, I think we got 30 plus of these, and these are on that website also. It gives you, background on cabin architecture, radiation protection, how to implement the standards that we had. I think you've heard over the last day, we are in the process of putting a new standard out for career dose to a crew member. Those will be coming out in the following month. We're going through the final approvals of those actually next week, and we'll be publishing those documents in December, and they'll be on this website. So you can take a look at all the changes there. One of the other key things here, we do have one that's called medical care and spaceflight experience. This basically tells you what a crew member experiences in the first day, the first 3 days, 2 weeks, 4 weeks. It also gives you guidelines from a selection point of view of things that you need to be worried about. Just for example, if you're putting up a crew member for a long duration mission, which is in our mind is more than 30 days, up to 6 months, and you are at risk for kidney stones, and you're going to be losing bone mass during that period of time. If you have a past history of kidney stones, that would require further evaluation. In the past, NASA usually doesn't fly people on long duration missions that have a propensity for developing kidney stones, because you're putting additional stresses on the body with fluid losses, loss of bone, loss of calcium. So those are factors that need to be considered as you put people into space going forward. We've worked on a lot of different countermeasures to enable people of all types and to go forward, and we're looking to expand these standards to provide that guidance so that even more people that haven't flown in the past can fly in the future. So once again, if you go to this website, you can see an overview of all the different standards, how to apply these standards, and bottom line, it fits in with the risk mitigation, because in order to mitigate the risk, we have standards and requirements that basically are guidelines that tell you how to safely go into space and bring the right things with you and ensure that you have a safe and productive mission. And that's the end of my slides. So Mary, I'll bring it back to you.
Thanks, Dave. Next up in our group of speakers is Steve Platts, Chief Scientist in the Human Research Program, and he will talk about upcoming research endeavors. Steve, are you on?
I am. Thank you very much. Let me share my slides here. How was that, Mary?
We're seeing your presenter view right now.
Oops. Okay, good. So thank you for allowing me to speak to you today. What I'm going to talk about is the way that
Steve, we're
yes.
seeing your presenter view and not your full screen.
Oh,
If you
okay.
could go up to your display settings and swap screens, or just duplicate.
Wow, you're asking me to do something I don't know how to do off
So on
the
your
fly. Okay, 1 second.
So we're still seeing the presenter view. So
I'm working on it.
okay. Yeah, from that drop-down setting, there should be either swap or duplicate. Either will be fine.
Okay, how's that?
And then just go ahead and pop it into presenter view.
I
And
have
that's
it in
perfect.
presenter view. Good deal. All right, great. So what I'll be talking about today is the research approach to these risks for going to the moon and Mars. So in many ways, I'll be expanding on what you've already heard in this session. And so the Human Research Program reduces risk through better knowledge, standards, and technologies. And we use the same hazards that you've heard about. We reorganize them a little bit and give them an acronym, because we feel like, because we're NASA, we should have an acronym for everything. So we created the acronym of RIDGE, where R stands for radiation, I is for isolation and confinement, D is for distance from Earth, G is for gravity fields, and E is for environments. And this helps us to organize our risks as well as to understand our risks. And this is how I like to communicate the risks when I'm talking about Moon and Mars. So on the far left-hand side, you can see the hazards in bold, so radiation, distance from Earth, isolation, etc. And we organize the risks by those hazards, as you heard from Sharmi. Now, these colorful columns, they are the different design reference missions that we work towards. And so the one furthest on the left is low Earth orbit. So that's what we're doing now with the International Space Station. And you can see we have a mix of green and yellow risks. And as we move towards the right, we get further away from Earth and longer duration. So we have multiple DRMs for lunar that covers most of what we'd talk about in the Artemis mission. So we have lunar orbital short, lunar orbital long, lunar orbital and surface short, then lunar orbital and surface long. And you can see as we move towards the right, we get fewer green risks and we have more yellow risks. And as we get towards lunar surface long, we actually, I'm sorry. We actually get more red risks. As we get further to the right for Mars, we end up with mostly red and yellow. And finally at Mars Planetary, we have red and yellow. And so this helps us decide how to spend our resources, how to spend our time, which risks we need to work on for which missions. And our research philosophy is to do a phased approach. So we do work on Earth, we do work on low Earth orbit, and then we'll be doing lunar missions, all to help us get to Mars. What we do on Earth is a combination of different analogs that we have, whether they're bed rest or isolation or radiation experiments. I'll tell you a little bit more about that in a second. In low Earth orbit, that's the International Space Station. And should we ever have access to any other commercial low Earth orbit stations, that would be a potential as well. And then finally, for lunar missions, that would be the Artemis program and the research we're designing there. So here's what we do on Earth. The Hera is a short duration isolation facility that we have at Johnson Space Center. We do a fair number of experiments in Antarctica. That's a little different type of isolation. That's isolation in an extreme environment, so the psychological stress is a little different there. And then we do longer duration isolation experiments at the NEK facility in Russia. That's where the Mars 500 was done. We just recently launched an 8-month isolation study there last week. The NBHAB facility is in Cologne, Germany, and that's where we do our bed rest studies. We've done multiple parabolic flights. These currently fly out of France. And then the NSRL is our radiation laboratory that's housed at Brookhaven National Labs. So just to give you an example, that Sirius 21, that's the 8-month mission that we just started last month. The focus there will be on crew autonomy. You can imagine that as we think about going to Mars, that's an aspect that will impact many of the risks that we see. Also isolation and confinement, international crew, team dynamics and mixed gender, a number of different behavioral health and performance type issues that we'll be addressing there. For low Earth orbit, there are a number of things that we do there. We have an active research program, and we can do simulations. We can do a number of different things. One of the most important things we can do is look at longer duration missions. So this is taken from the previous 1-year mission that Scott Kelly participated in, and the twin study that Scott and Mark participated in. This was written up in Science Magazine. It was a very incredible experience working on this research. We got some incredible data. It was a great pathfinder for doing longer duration missions. And so we've proposed a series of longer duration missions called CIPHER, and that's the Complement of Integrated Protocols for Human Exploration Research. And this is a group of 17 experiments combined into one complement that include astronauts from short duration missions, standard duration missions, and then longer duration missions similar to the 1-year mission. And these are the 17 experiments that make that up. We essentially cover all the organ systems, some very important things. The iSafe study is looking at SANS. We have cardiovascular studies, bone, a telomere study following on from the original twin study. And then we have a data integration specialist also working with these teams to integrate all the data and make sure we get the most out of it. 12 of these studies are NASA sponsored and 5 of the studies are from our international partners. So very well integrated group of studies that we're really excited to get moving on. And then finally, the lunar phase. These are the Artemis missions. We're working now on how to integrate our research into the early Artemis missions, and we're even working on what some of those later Artemis missions might look like when we land on the lunar surface. So our philosophy here is to be as unobtrusive as possible, as non-invasive as possible, to do in-depth characterization of the individuals so we can understand the individuals and potentially, work on individual countermeasures for the crew members. And then this applied research approach will be done across the missions to benefit Moon to Mars. And here's a quick listing of what we're seeing as the early surface science. And these are the payloads that have been proposed. And you can see that, like I said, they're just payloads. So ultrasound is very generic. What we would do is if we get that payload, then we would identify the experiments needed there. And those could be things like SANS doing ultrasound of the eye, ultrasound of the heart, veins, arteries, looking at kidneys, skeletal muscle, lots of different things that we can do there. And then we're also looking at crew and team performance measures, our standard measures, which is a small set of measurements that we take on all spaceflight crew, and it gives us sort of like the blood pressure and heart rate of different systems. It gives us a baseline of data that we can look to. It allows us to see what's happening to the whole body system when we're testing countermeasures. We'll be doing, hope to do dry saliva sampling booklets to look at immune responses, crew health and data management, having a heart rate monitor aboard, looking for lunar ascent and descent dynamic load injuries, alterations in multisensory integration due to combined hazards, and then finally blood analysis looking at biomarkers for a number of different systems. So these are the ways that we hope to address the risks for Moon to Mars. Thank you very much, and I look forward to answering questions in a little bit.
Thanks, Steve. Appreciate it. Okay, so I will start my video. And Ricky, I'm going to try to share my screen. Are you guys seeing them?
No, we're not. I can do that for you if you'd like.
Why don't you go ahead, because I had trouble last week when we tested it, and I'm worried that it's still acting up for me. Thank you. So John, you said that I could correct you. I am still just the acting Assistant Director for Human System Risk Management, but I do look forward to talking through this. I hope that what you guys have seen in this panel so far is kind of how each of the pieces fit together. And now I'm going to try to talk about how the Human System Risk Board takes all this information together and views the risks themselves. So the next slide, please, Ricky. But before I kind of go into our framework, I want to set the stage. The epidemiologist in me really has the need to kind of put the numbers into perspective. So the number 20. The first modules flew to the International Space Station in 1998, and the first crew were permanent residents came in 2000. So if you're younger than 20 years old, you've never been alive in a time where we didn't have people permanently in space. But 20 years is still a very, very short period of time. The number 580. There's roughly 580 individuals that have ever flown in space. Compare that or contrast that with 3,000, right? That's the low end that the FDA considers to be acceptable for a clinical trial to determine whether or not, a phase 3 clinical trial in particular, to determine whether or not a medication is effective. Throughout this whole year or two, the pandemic, we've been getting all sorts of information about the numbers that are necessary in a clinical trial to determine whether or not it is safe and effective. And finally, I'm going to contrast that with 1 billion. That's the number of individuals that got on a plane in 2016 in China alone. So when we look at those numbers, all I'm forced to say is that the evidence base is really very small. It is a very unique and diverse group of individuals, but it's still a very small number of individuals. We've heard from a lot of different panelists that we've talked about how generalizable that are, how the population has been largely a healthy, homogeneous group of males throughout the astronaut corps. That diversity is changing over time, but still it is possible that the evidence base that we have to date isn't generalizable to the general population, and that ongoing efforts to advance the diversity within spaceflight, be that within NASA's own efforts, be that within the commercial providers, be that within our international partners as well, that opportunity to grow that evidence base I find very exciting. And I hope that we learn more that can make our risk postures more generalizable to the population. I do also have to credit Eric Antonsen with the slide and idea. He's my predecessor, and so I kind of stole it from him to make my points today. The next slide, please. You guys saw this slide. Steve went through it and described it really very, very nicely. But at our board, what we tend to do is have the subject matter experts evaluate the evidence base for each one of the risks that are listed there. There are 30 risks. NASA has a set of countermeasures and information that's put together, and those countermeasures and information help us understand each of the risks for the different DRMs or design reference missions that are across the board. There are 8 DRMs and there's 30 risks. It becomes really very important to take all of that evidence and pull that together to understand human system risks and to understand how to mitigate and manage the human system risks, as well as we got to come up with a simple tool to explain it. This framework of looking at the likelihood and consequences of the risk, and then assessing based on those likelihoods and consequences, that stoplight charts, that green, yellow, and red, allows the complexity to be conveyed. It also allows the groups to communicate to other forums this way. Steve explained how he likes using this because it makes it clear. This is the current risk, Human System Risk Boards, or HSRB's risk scorecard, or as of June of 2021, with the driving risk posture shown here. There can be many other risk postures behind this, but the driving one is shown here. Next slide, please. I can also kind of look at this complexity and try to convey it in a different way. And I can start to look at the different, on the left, I can look at how the crew is impacted by the mission. I can look at exposure sources. I can look at isolation. I can look at altered body function. And I can categorize the risks into those groups. If I look at exposure sources up there on the top left, you can see carbon dioxide, celestial dust, toxic exposures, sunlight, and radiation. These are some of the exposure sources that the other panelists with me have described. I can then turn that around and say, if the human is undergoing these risks to themselves personally, there's also the possibility that they are then going to be impacting the mission. So how could those individuals impact the mission? How would exposure to something result in impaired ability for anomaly response? How would an exposure to something or a change in the health of the crew members impact contingency planning? Nothing in either these or the previous graphics that we've shown shows the integration between the different risks. It actually is very complicated when we start to look at, well, the risks don't exist in isolation. So how do we do this in a less complicated or a way to explain the complexity? So on the next slide, we'll show what the HSRB has been looking at over the last year and a half or so. We've moved to using the epidemiological tool of directed acyclic graphs. DAGs are the visual representation of causality in a network graph format. The SMEs put together all of the information just like they would put together and create this graphic format, SMEs meaning subject matter expert, I apologize, and look at how is the visual representation of each risk look. What are the nodes? What are the countermeasures? What are the contributing factors? How do we want to bring all of that in to tell a story? We use them directed in that they are single-headed arrows showing the direction of a relationship. We are acyclic, okay? There are no cycles. The relationship goes from one way. There are no directed paths to a node once you've left that node, right? There are no feedback loops. Now, any of us that have studied human physiology or science for some period of time, we know there are feedback loops. We understand that this is an imperfect way of looking at the risks at this point. Let's look at it in the vein of we are going to crawl first, then walk, and then we will run. Right now, we're looking at them in this fashion. What I plan to do in my next slide is through a couple of risks examples so that you can start to get a feeling for how the HSRB is evaluating these risks and how we can then start looking at common terminology and so forth to develop that integrated risk network and address some of that complexity that's been in the past harder to do. The next slide, please. Oh, Ricky, go ahead and click again. I didn't realize there was an animation here. Oh, go back. Not all showing up. Oops. Okay, go ahead and go to my next slide. So what I had intended to do was compare and contrast a simple risk with a more complex risk. And the exposure to ionizing radiation that I tried to show on the previous slide is actually an injury that could occur from exposure to a laser or to the sunlight in space flight. It could actually be considered one of these medical risks. The reason why we at the HSRB treat it differently is that it has its own mitigations that are specific to the vehicle and the suit and operations. And so it's managed in a different pathway. Think of it as, again, just one of these injuries when we look at the medical risks here. So in this graph here, you can see in the yellow nodes, you can see the 5 risks to spaceflight. You can see them pathing through some blue nodes, and then there are black and green arrows over to the right that end up, again, with some look at loss of mission objectives, loss of the mission itself, loss of crew life, potential evacuation, flight recertification, and long-term health conditions. And so all of our risks have a framework that are looking like this. We're actually trying to harmonize all of the terminology across this so we can build this kind of an integrated network. In this particular graph, we collapsed total medical events, that which is in the red box, into environmental injury, traumatic injury, and medical illness. And I think intuitively that can make sense that the pathways for causation are different along those lines. The treatments and the operations might be different along those particular lines. The planning for the mission might be different. This gives some clarity and some ability to handle the risk mitigations appropriately going forward. The non-ionizing radiation one I tried to show you actually is an environmental injury here, and it would be held within that box there. So Ricky, if we go to the next slide. We've now in this one collapsed all of the medical events down to a single node for clarity. to make the graphic a little less complicated looking. I will have you know that NASA, when they do planning, plans for 100 different medical conditions. The treatments and the diagnostics that go with those 100 medical conditions is all part of this planning. So if I were to expand that, you could see that this graph would be not intelligible to be able to understand. So the next slide, Ricky. So let's look at other risk interactions. So one of the things when I was trying to make my points on risk complexity, I was talking about the different risks. The blue circles here are where we've collapsed everything that has to do with EVA operations and everything we've has to do with environmental conditions. We've collapsed those down to try to understand the environmental risks and the EVA risks. The gray nodes here are the boxes. We want to look at other risks in here, and those are now in the blue boxes on here. And so the environmental risks nodes include toxic exposure, SANS, the spaceflight associated neuromolecular syndrome, exposure to microgravity, decompression sickness, hypoxia, exposure to CO2, etc. All of those that are listed here in the box. The other risks nodes look at the stressors from spaceflight and the changes to physiology, like the immune risk, the microhost risk, the food and nutrition risk, such that if we don't have sufficient food and nutrition, the crew members might not be available to perform activities. The deep vein thrombosis or venous thromboembolism that was talked about earlier today. All of those feed into, again, the total medical events. And then you can see the green lines going through, again, those things on the right, through crew capability, task performance, loss of mission objectives, and loss of mission. We've got lines to evacuation. We have lines to loss of crew life. We also down at the bottom, on the bottom right, have those things that are important for flight recertification so that the astronauts can then be available for future space missions as well now that they are trained. And we have long-term health conditions. And that is part of one of my other roles within the Lifetime Surveillance of Astronaut Health program, which was talked about quite a bit yesterday. Next slide, Ricky. So in risk complexity, I'm going to put out some things for thought, food for thought. How do we identify? Now we've kind of expanded the medical risk here in that graphic, and you can see the much more complicated nature of the medical risk. So how do we identify where to most effectively mitigate all of this risk? Or the most important parts of this risk? What knobs do we turn to help the agency mitigate the risk? What knobs would commercial providers turn so they can mitigate the risks to their crews? What happens when we integrate this risk with all of the other risks? Which touch points within the different nodes are of most important? What happens when I change a risk here, a medical risk, but it then impacts another risk? As an epidemiologist, advanced modeling techniques are obviously needed to help us understand this complexity. An expanded evidence base is also important and will help us understand this. And I'm a proponent for the more we can learn with the different crews that are flying outside of even NASA, the more that we can help more effectively mitigate risk. So in conclusion, Ricky, my next slide. Space travel is an inherently risky endeavor, and the nature of human risk is complex. I hope I've made that point, and I hope my co-panelists have helped describe how NASA is adjusting to this as well. Human exploration requires both an optimum functioning of both the spacecraft and the astronauts, right? And so failure in either of those systems can result in loss of crew or those mission objectives. The use of DAGs here is our trying to show how we could lose the crew or mission objectives and illustrate that for communication purposes. We have found that using the DAGs has been very, very effective in communicating with non-subject matter experts. All of the thinking around a particular risk is really important when you put it in that kind of a graphical format. And again, at the Human System Risk Board, we really like to think that our current Human System Risk Framework provides opportunities for the application of analysis techniques and so forth to further our risk management. And with that, that is the end of my remarks. And so we could go to the panelist and panel and take questions.
Thank you very much. There are a number of questions for each of y'all. I guess this first one is for Dr. Watkins and perhaps Dr. Platts as well. Are y'all thinking about using a centrifuge for use for long duration space flight? And wouldn't its use be helpful in terms of decreasing the number of countermeasures that would be needed during the space flight?
Well, that's a great question. I can give a quick answer and then pass to Steve, because I think Steve has done some more thinking on this. But yes, from a gravitational adaptations challenge perspective, certainly centrifugation would be helpful. The challenge is in the engineering implementation of the centrifuge. You know, would it be a short arm centrifuge, or would you have a whole vehicle rotating? So it's quite an engineering challenge, but from a human physiology perspective, could be quite helpful. And Steve, if you want to comment on what you're doing within HRP.
Yeah, I agree. It sounds like a great idea, right? You'd get multiple organ systems that you could treat at the same time: cardiovascular, bone, muscle. The engineering is incredibly difficult. And also, how would you do the prescription? So a lot of the adaptations that we see going into space are exactly that. They're adaptations. It's your body getting used to being without the gravitational vector, fluid shifts, all of those kind of things. If you were to then use a centrifuge daily, for example, what you're doing is then returning the astronaut to a more Earth-like environment. And then as soon as they stop, now they'll have to readapt all over again. And some of those adaptations aren't fun to go through. When we talk to astronauts, we hear about the congestion, the loss of sense of taste and smell, headaches and things like that can occur. So it's a double-edged sword. Yes, it seems like a very good countermeasure, but there are some drawbacks, and probably the biggest really is the engineering of it. Now, if we could rotate a whole vehicle and we could have constant gravitational artificial gravity, you know, that would be different. But again, the engineering there is even more difficult than just having a short arm centrifuge on a space station or something.
Thank you. And Mr. Francisco, could you explain the differences between standards and requirements and how you think that would affect the hardware and flight and medical requirements, or the medical things that are done?
Sure. So standards at an agency level. So that's when we generate a standard. That's where we basically are setting a risk posture to say, this is what we are comfortable with from an agency level. Those standards are broken down into individual program requirements because each program has its unique design references. So you have to tailor those standards to develop individual program requirements. And I mentioned, like, we can generate a list of selection standards for both long-term and short-term, but you would never use the long-term requirements for a short-term mission. So they're always tailored and they're always focused for that individual program. Same thing with vehicle design. If it's a shorter mission, we allow, you know, a little more leeway on some of those designs. But if we're going to keep somebody in that capsule or in that space station for 6 months or 3 years on to Mars, or sometimes it's a little more restrictions on those requirements. So we tailor the standards to those. So I think the biggest thing to answer your question is program requirements at an agency level. Program or standards are at an agency level. Program requirements are specific to an individual program, and we work to tailor those to ensure that the vehicle meets the performance and the crew members are the risks are safely mitigated.
Thank you. Dr. Van Balen, it appears that the Human Systems Risk Board is very important for looking at the potential risks. Could you describe who's on the board and what their expertise are, and how they actually make decisions for a particular risk?
Okay, so I will set the stage with the HSRB really looks and evaluates, let's call it the evidence base. It's our knowledge. It is the underlying knowledge that we have then to inform those that then work with the spaceflight programs on whether or not standards or requirements are being met. So I want that piece to be understood well as far as what we do at that board. The board is composed of a mix of technical experts and as well as a mix of management that control resources. I think there's an important mix there. And again, these are my opinions on that, but I think there's an important mix in that. You need some technical expertise so that the technical experts can weigh in and talk through the understanding of what's being vetted at the board and large community conversations. But you also need to have some individuals that control resources and understand those trades that need to be made as we build our evidence base. So for example, as chair, I'm on the board. I had a previous role as a lead epidemiologist. And so I sat there from an evidence base to understand that. I don't control resources in a way. I get my budget from somebody else. So I'm not the resource side. Steve Platt is also on there. And he brings his chief scientist role to the board, to those conversations to talk about what the research can tell us about the evidence base. But then David Bauman, as the program manager for HRP, is there in a resource kinds of conversation piece. The next piece that goes with it, I would say, is we also have the Chief Health and Medical Officer and our deputy, and so Terry Taddeo is part of that. And so you get a mix of science, you get a mix of medicine, and you get a mix of resource controllers, if you will. Hopefully that answered the mail.
Thank you. And as a follow-up, Dr. Platts, talking about the evidence, and I know that the Human Research Program has evidence papers, which is a book. Could you describe that and tell the audience where they could obtain or look at those evidence reports?
Sure. So what we do for each risk is we maintain what we call an evidence book. And it's essentially a review paper written by the discipline within HRP, and then often bringing in outside experts as well. So some of them are 10 or 15 pages long. Some of them are up to 100 pages long, depending on how much evidence and how much has been written about that particular risk. And so those are submitted to the program, and we review them, and then we have historically had them reviewed by outside panels as well, just to make sure that we're not missing something and to give us sort of that extra level of scrutiny. And then we put them online, so we use them for our solicitations. They're made available so that folks can read them, look at them. They're publicly available. If you go to the HRP website, there are links on there to the evidence books, and it would allow folks to look at those. And when they're writing proposals, it's very helpful. You know, if you're writing a proposal for, cardiovascular risk, you can go in and see what evidence there is for that risk, what work has already been done. It's essentially, it is like a review paper. So they're very informative, very useful, and available as links through our public-facing website.
Thank you. Dr. Watkins and Dr. Platts, a question on, will everything have to be brought with the space missions for the crew for food and health purposes, or will there be able to have in situ or on-site manufacture of supplies, food?
Yeah, I think it'll be a mix. I think most things we will bring with us, the things that have sufficient shelf life. It'll be nice to know that those are with the crew. There are also opportunities to pre-position supplies. Again, those things that have a long shelf life, we could know that they're there in advance. And then there is still the opportunity, as you say, for in situ resource utilization. So from an environmental perspective, we could be generating some of the breathing gas. We can reuse humidity in the air for drinking water. And there's the potential also to use, grow our own pharmaceuticals or grow food. Probably not sufficient to sustain the entire mission, but as an augmentation, that could be incredibly valuable. Steve, do you want to add anything?
I think you did a great job describing it. The one thing you mentioned, potentially 3D printing pharmaceuticals. There's also been discussion about 3D printing of food and other things. So there's all kinds of potential, and it'll be really interesting to see what happens in the future, what technologies are developed, what new things we can do. When we first flew an ultrasound machine on the space station, it was a full rack. It was about the size of a refrigerator, right? And now it's a laptop, and we're getting ready to fly pieces of hardware that are this big as a full ultrasound machine. So just imagine what else we'll be able to do in 5 or 10 years. I think that's an exciting prospect.
So although there are many other questions, it is 2:30, so I'll turn it back over to y'all.
Thanks, Victor.
Thank you all very much, Dr. Van Balen and all of you on the panel. Thanks so much. Actually, that last question was perfect, sort of a tee up for tomorrow, because it really is very forward thinking. And that's, today has been a look at what's, a day in the life sort of Dr. Serena in space, what actually an entire 197 days in the life for her mission on space station. Going all the way from that, looking across really through the different panels of how we've gone from that spending time in space to how do we manage to get people to be there, and that's through the leadership activities across a real broad spectrum. And that second panel really looked at that broad spectrum of not only the leadership within the space medicine community, but also in the architecture and engineering community, and then led really nicely into the next panel discussion where we're looking at habitats, EVA suits, all those kinds of combinations, those modifications that need to be made for individuals to be able to spend a long time either in space or on a planetary surface itself. With Dr. Williams bringing in that important discussion about the need for crossing the boundaries between engineering and medical to have a common lexicon to be able to work well together. And I think that's really where this last panel shows that as you work with the standards and requirements, as you work with the boards that sit there and make the decisions about how to make this an effective and safe environment for humans, it is that cross discussion so that human system integration takes place, so that individuals are considered as part a system within the bigger body of systems, so that individuals are safe to fly. I always learn a lot from these conversations. I hope that you have as well. Again, tomorrow will be more discussions looking more in future focusing. And I hope you can join us for that. We have mentioned several times that each of the days are being recorded. Those are now, there's a link for that now. If you go back to the original Spaceflight for Everybody webpage where you had to register to participate in each of the days, at the top of the agenda for day one is a place that will say recorded sessions. And so you'll be able, I'm presuming that it'll be one of those for each day. So you'll be able to go back and look at those recorded sessions for that day. Dr. Siegel, is there anything else that we need to mention before we let people go today a little bit earlier than yesterday?
The only comments I really wanted to say was, first of all, I was so pleased with the presentations today. I appreciate so much that people were really candid in their discussions and sharing their own experiences, of course, as well as the medical data and information that we heard. To me, it was very enlightening, and I really appreciate it. Again, I'd like to thank Ricky Guest for making sure that all of our little glitches were very short-lived and that the pace of the meeting went really well. And thank all the people, all the presenters as well. And I look forward to hearing it tomorrow. We will be back at 10 o'clock tomorrow morning.
And once again, thank you to our sign language interpreters for keeping up with us and doing such a marvelous job. Thank you.
Thank you.
All right then, folks, thanks very much. We'll see you in the morning.
Take care. Bye-bye.